I think with all the data that is available, I think one thing that is very clear is that cumulative pregnancy rate from a cleavage stage transfer resulted in higher clinical pregnancy rather than from Blastocyst cycle. Even if you not say higher, but at least it was giving us equally good results. Because if you can see in the image here, see, if you look at one IVF cycle for particular patients, when you have multiple when you have multiple cleavage stage embryos, actually the same embryos only are developing into blastocysts. So by transferring that, probably the only difference that is going to be made is that time to pregnancy or the chances of them to get pregnant quicker happens when you're doing a blastocyst transfer. So if you look at the different articles or studies that we published, this is one article which was published in 2016. I'm taking only the very recent articles that have been published. They said that when you're doing a fresh transfer, that is as a first transfer, obviously blastocyst transfers are giving us slightly improved results. But when we're looking at a cumulative pregnancy rate, where we add in all the fresh transfer as well as the frozen transfer, there was no difference that was found. If you can look at this forest plot also, you can actually see the first forest plot, which actually says that the day 5, day 6 is having a better pregnancy rate. But when actually looking at a cumulative pregnancy rate, we can actually see that there is no advantage of day 5, day 6 versus day 3. Similarly, a Cochrane review was published in 2016 questioning the same issues, and the Cochrane review also did come up with the conclusion that the cumulative clinical pregnancy rate from cleavage stage resulted in higher clinical pregnancy rate than from blastocysts. Similarly, even after that, there were several studies that came in after that Cochrane review, wherein they said that, okay, when you're talking about a good prognosis patient, see, now when we have multiple embryos, not necessary that the first day 3 embryo that we are going to transfer probably can be the potential embryo that could develop into a blastocyst. So it's not, sometimes it is never that it is going to be a quicker pregnancy. Sometimes we can get the same pregnancy rates even with day 3 or day 2 embryo. So in this particular study, they said that especially in a good prognosis patients where you have a lot of embryos, in that group of patients, probably looking at a single embryo transfer, then a blastocyst can be better. This again is a very recent 2020 retrospective cohort study. They compiled a lot of data, which they were able to, they looked at all the data that has been published in the HIFA, and they took out the data and they analyzed it. In that particular data, they were able to analyze that, yes, the clinical live birth rate the cumulative live birth rate was increased in those who underwent blastocyst transfer. But when you're accounting all the imbalances between the exposures, then blastocyst transfer did not have any. So when you're actually removing all the odds from that particular study, we're able to understand that blastocyst transfer did not give an improved live birth rate. And the most recent, this is published last month, the cleavage stage versus blastocyst stage embryo transfer necessary production, where they looked, they documented saying that there was a very low quality evidence for live birth and moderate quality evidence for clinical pregnancy that fresh blastocyst stage transfers associated with higher pregnancy rate. But they were very uncertain because they were not able to compile the full data, so they were uncertain about the blastocyst, whether blastocyst stage transfer improves the cumulative clinical pregnancy rate derived from fresh and frozen thought cycles following a single oocyte retrieval. For a single cycle, whether, but logically, if you look at it, it is not necessary because it's the same embryo that is going to get grown into a blastocyst. So if the patient is getting pregnant in that particular cycle with the blastocyst, she should have got pregnant with the same embryo which was on day 3. So to conclude this part of this particular session, we were able to understand that the blastocyst transfer can probably increase your live birth rate per embryo transfer, but when you look at the cumulative pregnancy rate, it does not. The second question to be asked, whether are we losing embryos? Not, it's understood that not all embryos of day 3 are becoming a blastocyst. So we are going to have lesser embryos to be cryopreserved. At the same time, we are also having or facing situations where we do not have embryos to freeze. So even in these group of studies, the same studies, when we're looking at that aspect of this particular entity, we were able to understand, or it was clearly proven beyond doubt, that when you're doing a day 2, day 3 embryos transfer, we are having more and more embryos left with us to cryopreserve. When you have more attempts, when you have more number of attempts, there's always a higher possibility of getting the patient pregnant, there are also a higher incidence of cycle cancellation there, especially when you're looking only for blastocyst transfer. There's also probability that we don't have any embryo to transfer. So these were the issues. For example, even the latest Cochrane review that is published in 2022, they did very clearly mention that only 60% of the, when 60% of the women in the who are doing cleavage stage transfer had embryos to cryopreserve, only 30% or 50% of them had embryos to cryopreserve when you're doing a blastocyst stage transfer. Similarly, when only 1% of the people who were doing a cleavage transfer where we did not have embryos to transfer, at least 2 to 4% was there when you're doing a blastocyst transfers. That is where we are not able to do a transfer because there was no embryo developed into a blastocyst. So when you look at this entity, what we were able to understand is that when you are doing a blastocyst transfer, there's always probability that we are left with less number of embryos, and there's always this concern of increased incidence of cycle cancellation. Now coming to the third entity, if this whole extended blastocyst culture is going to cause any harm to the embryo, what are the obstetric and perinatal outcomes? What is the incidence of monozygotic twinning? Is there something called as an altered sex ratio in this particular issue? And this was one of the studies which were published in 2014, and probably I think this was the only study which they actually were able to establish a statistically significant increase in congenital abnormalities in patients whom they have done a blastocyst stage transfer. But following that, the reports were not much. But again, this was a very interesting article where they debated on the stage 3 transfer versus the blastocyst transfer, and they were able to evaluate the evidence, and they came up saying that when you're doing a blastocyst transfer, there's always an increased incidence of preterm delivery, LGA babies, monozygotic twins, altered sex ratio, and also an increased congenital abnormalities. Now, the congenital anomalies in this particular study was referred from the previous study that I had talked about. Then this is a very recent article, which is again, they took up the data from all the Nordic countries, and they looked into the obstetric and perinatal outcome in these group of patients. What they were able to understand, as far as the obstetric outcome is concerned, there was a statistically significant increase incidence of placenta previa in patients with blastocyst transfer. With regards to perinatal outcome, yes, there was definitely an altered sex ratio. There were more males as far as females when concerned when you're doing a blastocyst transfer. At the same time, there was also an increased risk of preterm birth. So if you look at the incidence of monozygotic twinning, if you look at the incidence of twinning is higher even when you're transferring one embryo, whether it's blastocyst cleavage rate. When you're transferring one embryo, the incidence of twinning is higher. Even the incidence of same-sex twinning, so where we are looking at thinking of like kind of a monozygotic twinning that is happening, the possibility is higher when you're doing a blastocyst transfer. And all of you know that the possibility or the risk of monozygotic twinning is much higher in a. So now we look at another very recent article that is published where they looked into the outcome, obstetric and perinatal outcome. Even they also claimed the same, or they also came up with the same inference that there's a higher risk of preterm birth and large for gestational age babies when we are actually looking at patients who are born out of blastocyst stage transfer. Now, there is always this concern that whether there is some kind of, even in this particular article, they did talk about there's an adverse neonatal outcome, but what is the exact adverse neonatal outcome was not very clearly mentioned, but they felt that there was definitely an adverse neonatal outcome. And why do we talk about so much of adverse obstetric and neonatal outcome in patients with blastocyst transfer? Is what the possible explanation is that these extended cultures can trigger genetic and epigenetic changes in the trophodermal cells that can lead to abnormal placentation and implantation, and hence there is a possibility of all these adversities. So in this part of the scenario, when we're looking at it, we understood that blastocyst transfer has a higher risk of increased congenital abnormalities, preterm labor, placenta previa, monozygotic twinning, and altered sex ratio. So this altered sex ratio, the bigger challenge is that even if our PCPNDT people know that we are talking about altered sex ratio in blastocyst transfer, they might even ban blastocyst transfer. Now coming to a more practical, probably a more practical and an India-centric situation. See, one major challenge, I think what we always had is the number of embryologists, number of incubators regularly working embryology lab. That is unfortunately not there in 60-70% of the centers. So you need a lot number of incubators when you're talking about blastocyst transfer. There's a lot of embryology that is required, because now if you're talking about an external culture, we need to change the embryos after day 3 into a fresh medium. So a lot of additional work that is involved. The people need to be trained by both freezing both the day 3 embryo as well as the day 4 embryo. And one of the most important aspect is the requirement of a low oxygen environment. Not everybody has a tri-gas incubator, so that is going to be a big challenge. Even if somebody has a tri-gas incubator, they might not have the provision to acquire a medical grade quality tri-gas available. So that again, these all becomes technically challenging scenario. This was something that was mentioned in it was slightly an older sentence in the guideline of NICE, where they said that they suggested that extending the culture period into the blastocyst stage increases the risk of women having undergone treatment without any benefit, because our pregnancy rate was never increasing, but we are only putting these patients to a higher risk factor. And because of all, see, it's not that all the embryos are necessarily need to be transferred as day 2 day 3. Now there are countries where we need to transfer only one embryo. When you're talking about one embryo and when the patient is having a lot of embryos, at that point of time, probably doing a blastocyst stage transfer might become more logical. But then there is always a role for stage day 2 day 3 transfers, where people are actually getting equal results considering the kind of scenario or the system that we are prevalent in our country. To summarize, the extended embryo culture to blastocyst stage has the potential to compromise obstetric and perinatal outcomes, less embryos to cryopreserve with no embryos to transfer in certain situations, and all these issues with no additional benefit of improving the cumulative live birth from a single IVF treatment. So as an IVF specialist, I think it's also important for us not to achieve pregnancy, but also provide a treatment with minimal complication that is associated with IVF and safeguard the long-term health of the future generation. So with all these content in mind, I think we should always understand and decide that stage 2 day, that is the day 2 day 3 transfers, has to stay and will still have a relevance in today's scenario. Thank you so much.
Thank you very much, Dr. Parasu. So, Dr. Priya, your chance now.
Yes, I'm just going to open my... at the outset, thank you, Kundavi ma'am and Dr. Geeta, for having me here. And at the beginning itself, thank you, Parasu, for putting for every slide after slide after slide, that the blastocyst gives much better pregnancy rates. Thank you so much for that, Parasu. I think my job is already done, but still, let us just go through certain points, which Parasu has already mentioned like so many times and over again, that it's much better. I think you have left me with nothing to talk about, Parasu. You've almost done my bit by talking again. But however, then with the ART program and the ART law coming into the picture, it is now that we've had it in most countries. They have already mentioned that 2 embryos is the max you can have. In a blast, it can be only a single blast, and singleton pregnancy is a norm, because we don't want complication. Is not just having a placenta previa or things like that, obstetric complication. Any twin pregnancy is considered a complication in terms of as much as ART is concerned. And the next thing we always wish to have for our patients is the shortest time to pregnancy. Ideally, having 2 years long program for each person is not something patients would be very patient about, and they need to have it as quickly as possible. So looking into that, we have to devise programs. We have to look into protocols of how we can achieve a singleton live birth at the maximum amount from each IVF cycle, and how quickly it is possible to achieve that for our patients. Well, yes, we do know, despite the major advances, the implantation rates remain slow, and only a small percentage of patients do achieve a pregnancy. We are not able to have 80, 90 or 100%. But we also know that the health of an embryo, the endometrium and the embryo transfer plays a major role in this. We've had an increased interest in the blastocyst transfers, basically because of the increased implantation rate that it has been able to achieve rather than a cleavage stage embryo. That is per se is the underlying point on which we have to think of why we should not be looking at a blastocyst transfer for wherever it can be done. And there is actually a trial which is going on now, a randomized trial, asking, is there a role for a cleavage stage transfer? It is going on. And from this paper, they've already suggested this. I remember in 1998-99, I'm sure Sujata will remember as well, when Dr. Gardner published his paper and we were all doing the cleavage stage, and the moment he said about 50% success rate, we were in, what 50% success rate out of the blastocyst? Similar to that, this is another publication where it is clearly shown in graph the difference between in implantation rate, clinical pregnancy rate, live birth rate, differences between the day 5 transfer and the cleavage stage transfer. Obviously, we also see that the multiple pregnancy rates is also quite high when we put cleavage stage, because in a cleavage stage, we are unable to still go ahead and transfer one single 8 cell. We give at least 2 8 cells, which automatically increases the chance of multiple pregnancy rates. Again, back to what Parashu has said, the advantages of blastocyst transfer, the main advantage is the improved endometrium embryo synchrony, which increases the chances of implantation because it closely mimics the natural conception. When we take the embryos to a blastocyst, there is a self-selection process of the competent embryos, which means probably we are selecting the embryos with highest implantation for highest possible potential for implantation in pregnancy. And hence there is a higher implantation rate, clinical pregnancy rate, and a significant increase in the live birth rate as compared to the cleavage stage embryos. Yes, what we do require is an optimal laboratory conditions and improved laboratory standards with better culture media, which I think is quite okay now. Yes, there are other requirements such as low O2 and low oxygen tension, which probably the embryos will benefit from if you're going for day 5. I think with more improvement in the culture systems, everybody or most labs will be able to achieve a better blastulation rates, which I think is also one of the crux for the ART law, which has been implemented, saying that we must have certain facilities in our laboratory to have standard laboratory in the IVF program. Well, again, why we do have lower pregnancy rates in cleavage is probably the premature exposure of the early stage embryo to uterine environment, which can cause homeostatic stress, resulting in reduced implantation potential, of non-synchronization with the endometrium, the embryonic. Again, as we said, when we allow the extra time, we could probably improve, or not improve probably the embryo quality, but definitely allowing us to select the embryo which has got the best potential for embryo implantation. As in another study, the implantation rate on day 5 in a single blastocyst transfer was about 49% as compared to 33% in day 2 and day 3 transfers, even in the good prognosis patient, which is less than 35 years. And of course, there's a reduced myometrial and endometrial contractions on day 5, and hence the risk of blastocyst being expelled is also less. Another important additional advantage of having an extended culture is we could probably allow to have a PGT or a PGD being done through the trophectoderm biopsy and not day 3 biopsies. That is another advantage. And another major advantage is you need to transfer lesser number of embryos for a higher implantation rate and a higher pregnancy rate and a higher live birth rate when it's blastocyst transfer. Whereas in cleavage stage, we need to have the 2 embryos on day 3 to have a decent implantation rates. And the cryopreservation rates are also very good when it comes to blastocyst with vitrification, which can also increase your cumulative pregnancy rate. But yes, we would have lesser number of blastocysts to freeze, because 60 to 60, if we have achieved a 60 to 70% blastulation rates, it's pretty good. But then the embryos, we might have lesser embryos to freeze, but the embryos that we freeze have a much better implantation potential than when you freeze them in day 3. In terms of cost analysis, cost benefit analysis is something that everybody stresses on. In terms of number of incubators and everything, the number of personnel, but all we are doing, we know, is just keep the dish, change over the media. In some labs, some don't even change the media. From day 3 straight to day 5, you don't even do anything. All you have to do is check on day 3 and then check on day 5, the 2 days of extended culture alone. But then the cost of multiple pregnancy, and of course the cost of multiple embryo transfers when you're doing a cleavage stage embryo, instead of having a higher chance of pregnancy rate right from the first or second embryo transfer, having multiple embryo transfers is an added cost to the patient, number 1. Number 2, the chance of having a higher order pregnancy, such as multiple pregnancies, and the cost of the obstetric follow-up plus the NICU and everything is increased when it comes to multiple pregnancies, which is much higher during using cleavage stage embryos. That definitely, I think, beats the cost of having 2 days of extended culture. So I think I really don't understand that thing, because we are not looking at the cost of the multiple embryo transfer that we have to do when it comes to cleavage stage embryo. There's been certain other publications which have said that, yes, monozygotic twinning could be higher, was published to be, but some other publications also said that monozygotic twinning are the same when it comes to cleavage stage or the blastocyst transfers. I particularly did not mention both the Cochrane because I knew it would be reflected, which again has said that it is low to moderate quality evidence that blastocyst transfer obviously gives a better result. So the onus is on us to have a better quality lab conditions, to have 60% to or at least about 60% blastulation when every embryo then, which has got a good grade blastocyst, has got a much better chance of implantation than a day 3 embryo put together. And in terms of ectopic pregnancy, there has been significantly lower risk of ectopic pregnancy following transfer of single frozen blastocyst. That is what has been said in the large Australian the population-based study as well, because of the larger diameter of the various physiological advantages that a blastocyst has. And in terms of age, we always believe that we've always come so far that thinking that after a certain age, it's probably not good to have an extended culture. It's better to go as day 3 or day 3 embryos, so that we won't lose those embryos to day 5 when we take them to day 5. But there's been a study which showed that when patients above the age of 35 had a significantly higher ongoing pregnancy rates and cumulative ongoing pregnancy rate with embryo transfer on day 5 compared to embryos transfer on day 3. They said that in this particular study, they said that it did not have the similar advantage in women, in good prognosis women. But however, the Cochrane has mentioned that, has again mentioned in both the Cochrane reviews that it is advantageous in the good prognosis patients to have a blastocyst transfer. This is again, the publication has mentioned about the pregnancy rates in less than 35 years, 51 and 30, 25 to 20, and 25 and 23 in women of different age groups. Well, the most important question we come to when it comes to blastocyst stage is, can we use that? Can we go to a blastocyst in poor ovarian reserve? Do we have to necessarily transfer on day 2 or day 3 because we don't have that many embryos? Currently, what we do, the reason for cleavage stage embryo in large part is probably the fear of cancellation and thus eliminating any pregnancy. In women who give us very few eggs, Well, I guess we should be looking at our laboratory conditions. If it is good, when we can take them, then probably every embryo that goes to day 5, and we know that the blastulation rate and the day at which it blastulates has got a huge impact on the pregnancy rate as well. So our aim should be having, are we looking at having just an embryo transfer or a patient, or giving the patient a higher pregnancy rate? So in that case, if we do are able to take the embryos, or if it goes to blastocyst and we are able to convince ourselves and the patient that probably a day 5 would, even if it is 1 or 2 embryos to blastocyst and then transfer, the patient can have a much better pregnancy rates than in day 3. The valid question is, embryo which is on day 3, the same embryo goes to day 5, and hence why should you take it when there is no process of embryo selection in this case? The only thing we are looking at is in the conditions given. We know that the entirety of ART is not physiological, from stimulation to supernumerary eggs to supernumerary embryos to the endometrial preparation and the in vitro culture. None of this is physiological, and hence if in this non-physiological, if the embryo is able to go to day 5 in a non-physiological or condition which is, we are thinking, is as close to physiology as possible, if it is not able to go develop into a blastocyst, would it be able to do it in the endometrium, is a question that we could be asking ourselves. Of course, we cannot, probably we can never come to the accept that or have the overconfidence that our in vitro is always is probably equal to the endometrium. It's not. The nature is always better, but this is a question that we could be asking ourselves. Thank you so much for this opportunity.
Thank you very much, Dr. Priya. Dr. Parasu, you have a couple of minutes in case if you want to, talk against any of the points raised by Dr. Priya.
Yeah, I think, again, burns out the same question as now when we talk about all these embryos which are not able to travel to a blastocyst. And if it does not travel, you really don't know what is actually happening to those embryos if we would have transferred them earlier. So that was always a question or worry that is there in most of the people's mind. And that is one of the reasons that everybody do talk about, or most of the articles or recommendations that came in saying that if you're having lesser number of embryos, then probably do a day-to-day transfer. If that recommendation is that they strongly believe that day-to-day 3 is better in that group of patients, it should also be better in the other group of patients, is what I technically always feel. And like what Dr. Priya said, that yes, it's true, when you're talking about higher clinical pregnancy rate or live birth rate, it is per transfer. It is never, when you're looking at the whole clinical pregnancies, it does not really matter. So and this whole concept of a physiological window that is on day 5, day 6 is what we have been, I think that we have been hearing, which was in support of blastocyst. But I think there was those initial articles by, I think, Koklepiansky's and all, where they actually did talk saying that the day 5 in a natural cycle necessarily is not the day 5 in a stimulated cycle. They compared a day 3 endometrium to a day 3 endometrium of a stimulated patient to be in comparison to the day 5 uterus of a natural cycle. So if that the synchronicity was such of an issue, then probably we wouldn't have had any pregnancies with day-to-day 3 transfers, if the synchronicity. So that's why I really did not talk, or I don't think a lot of people do talk about synchronicity as far as day 5 is concerned, but people talk about, so I would not deny the fact that blastocyst transfer is good, but it's in science, it's never all and none. Unfortunately, in certain group of patients, you need to do a certain things. In certain group of patients, you need to do certain things. But when it comes to a lot of people, because it's my personal experience, a lot of people do talk about pushing that blastocyst transfer. I get better pregnancy. It's never better pregnancies you're achieving. So that is something I think which people should know, and that is what was my whole idea of speaking in my talk. Thank you.
Thank you very much, Dr. Parasu. So we heard both of them. Now, just to kind of, sum up, the salient points discussed by both. Dr. Parasu said it's the same embryo which is actually going to become blastocyst. So what is the need? He also said, was asking, would the embryo become blastocyst in a more natural environment than in an in vitro condition? And the other point was like, we would lose embryos in the process. And the fourth major point was the perinatal outcome. And Dr. Priya, she had said like, number of embryos you need to achieve pregnancy would be very less with blastocyst. Thereby, the multiple pregnancy rates would be less. And she also mentioned that the shortest time to pregnancy would be achieved with blastocyst transfer. Implantation rate would be better. There is a better synchrony, like a physiological process. And there is also, self-selection of embryos. And finally, she said, like, cost analysis. Like, you cannot say that culturing embryos for 2 extra days would be expensive when you are comparing it with the number of embryo transfers you need to achieve pregnancy. Now, so with this, they have discussed most of the points. So if you are asking me to kind of, like to give a final conclusion for this, some of the things, say, for example, Dr. Parasu had said, like, it's the same embryo. The embryo is the same, but the environment is not the same. Like, you are transferring the embryo in an environment which is not conducive enough to hold that embryo. So that is precisely the reason why the pregnancy rates are much, much lower in cleavage stage transfers compared to blastocyst stage transfer. And he also had mentioned that, like, there are pregnancies coming out of cleavage stage transfers. Absolutely, yes. Like, it is not at time to kind of say that, like, okay, we cannot do cleavage stage transfers anymore. But the point is, how many attempts do we have to take? Otherwise, you have to compromise by transferring more embryos, which again can be harmful to the patient. Now, there is also something, like which we have to differentiate between the statistical significance and the clinical significance. I do not know, Parsa would be, wouldn't he be happy if he can get one single patient of his pregnant compared to the previous months? It would definitely, impact on the practice, rather than just going for all this statistical significance. And this statistical significance, which is mentioned in the literature, even the Cochrane study or the much larger study, which he had mentioned, that had actually, happened between 1997 and 2014. Much changes in culture conditions in terms of culturing in low oxygen and, changes in the media components is happening in the last 4-5 years. So I think, we'll have to wait for more studies which actually would look at the cycles which has happened after, say, 2005 to come to a conclusion on the adverse effects of blastocyst culture. Now, another thing which I also would like to mention here is, Priya had already said, like, what is the actual idea of doing an IVF? Is it just to have an embryo transfer, or is it just to have live birth? There are several studies which have shown that the live birth rate is much higher with the blastocyst transfer than with the cleavage stage embryo transfer. So any direct comparison, any studies which actually does a direct comparison between day 3 and day 5, it just shows that the day 5 transfer is always better. And then regarding this perinatal outcome, see, there are studies which are coming up recently on PGTA. Most of these PGTA cycles are, like blastocyst culture plus biopsy, but where they have not noticed any abnormality or any, reduction in the perinatal outcome. So, if you extrapolate it, if at all, if there is any problem with post-blastocyst transfer, is it only because the embryos are cultured to blastocyst is a question which we have to ask from the evidence what we have on PGTA recently. And definitely a lab has to be very good to support blastocyst culture. And I personally feel that the blastulation rate is a surrogate marker for the quality of your lab, because which we will not realize it unless we do more of blastocyst cultures. If you are just restricting yourself to day 3, even a good prognosis patient can actually become negative. And here you will not suspect the lab, because you do not have any marker to know how good your lab is. So putting all these points together, as of now, we cannot say that blastocyst transfer is the, you should kind of do away with cleavage stage transfers. No, but blastocyst transfer is something which you really have to look forward to for many, many reasons. All those points which are mentioned there during their presentations. But if at all, if there are any problems with blastocyst stage transfer, I think we cannot just dump it and say that like we will go back to some primitive method. Rather, we should try to work out what is the problem which actually is causing all these issues and try to work on that. If it is, the culture conditions, or if it is, the, everything included in culture condition, like low oxygen, high oxygen, carbon dioxide level, the media components, etc. But I think, from where we were in 1960s, we have come a very, very long way. But if we have to move further forward, I think we have to embrace this and then try to culture more embryos to blastocysts. Ultimately, the clinical intuition and the patient's preference would also play a role. But with the current evidence we have, I think blastocyst culture and transfer is the way forward. Thank you.
Thank you, ma'am. Thank you. Thank you. This was a lovely debate and excellent judgment, I would say. The point which you said was like, to this blastocyst transfer is actually a surrogate marker to look at our IVF lab protocols and everything. That was really great. And we hope it's actually a long way, as you said, and we all have to slowly shift, but it is ultimately we need to individualize cases. And it is, this debate is always a debate in our mind. So whether we need to go for day 3 or day 5, as a clinician, it is always a debate inside us. And thank you, ma'am. Thank you so much. I think we can move on to the next session. Dr. Vani is ready with her presentation, so we can move on to the next presentation.
Hello.
Yes, ma'am.
I'll try to share first. If I'm
Yes,
not able to, then.
Yes, ma'am.
Okay.
Yes, ma'am. Done.
Computer will just. Good afternoon, everybody. Thank you again, Dr. Geeta, Dr. Kundavi, and team MMM. Anyway, it was an interesting debate, and my seed got ready and soil took some time to get ready. And I think that happens in the nature also. There is always some asynchrony or something happening between the seed and soil. But today's theme, as you already noticed, it is soil and seal or endo endometrial talk. So soil is as important as seed, if not more. My topic for today is to deal with thin endometrium. So we'll understand a little bit about thin endometrium. Right now, according to the current literature, we have the only thing we have to assess the accepting power of the endometrium. So when they give either cleavage stage or the blastocyst, once they finish discussing among themselves, they'll eventually give us an embryo. And when we are going to transfer that embryo, to assess the accepting capacity or the acceptability potential of the endometrium is, according to the current evidence, is only measuring the thickness of the endometrium at the late follicular phase. Even though the other points also, or factors also came in later on, like trilaminar pattern, or volume of the endometrium, vascularity and vascular indices, and endometrial receptivity assay. And the people who are doing all this, they believe that we have to do all this and then, or one of this or two of this, to before we transfer any embryo. But unfortunately, when we look at the evidence, at larger evidence or RCTs, or all the meta-analysis, we don't have solid evidence for rest of all these factors, but there is a reasonably good evidence for the thickness of the endometrium. So if the endometrium is thin, so it is implied that the implantation potential is less, or then the pregnancy rate will be less. So what happens if the endometrium is thin? Why are we worried if endometrium is thin? The endometrium is a layer which contains a lot of epithelial cells, a lot of stromal cells and glandular cells, and a lot of blood vessels. And this causes expression of vascular endothelial growth factor and several pro-implantation growth factors. So we need this many, this amount of endometrium, or this amount of cells and the vascularity and the things which come along with it, so that they can express themselves properly and accept that incoming embryo. And we do have a good evidence in IVF. There are several studies which say that if the endometrium is thin, we have a lesser pregnancy rate. But as far as stimulated cycles or IUI is concerned, we don't have a very good evidence that if the endometrium is thin, our pregnancy rate is going to be less. So we don't have evidence in that. But in IVF cycle, we do have a reasonably okay evidence. I will present to you about that in a minute. So when we say thin, how thin is thin? Okay, so 7 millimeters, 8 millimeters. Again, evidence is all over the place, and there are several studies. We have looked at several studies, and then there is a guideline which is published recently, and everything is sort of between 7 and 8 millimeters. So if you want to take a decision of postponing or abandoning or doing something to improve your endometrium, so you're looking at 7 or 8 millimeters endometrium. So below that, you want to do something about something to your endometrium to improve it, and above that, you can say, okay, I'm reasonably okay, and I can probably go ahead and transfer. Even though there are several case reports or case series which show that it is not zero if it is below 4 millimeters, and the pregnancies have been demonstrated even at 3.8 millimeters. So they're all case series. So when you look at a larger evidence, we do have a lot of studies focusing. Somehow many authors are taking this number as 7 or 8 as a cutoff for their studies, and whatever evidence they are publishing, it is based on this taking 7 millimeters or 8 millimeters. So when we have evidence for that, so we can only think about that, but it's not written on the stone. So this is the guideline I was talking about, published in RBM Online. They have looked at several papers, observational studies, RCTs, meta-analysis, and everything possible. And they've looked at clinical pregnancy rate when they take endometrium as 7 millimeters, or when they take as 8 millimeters, or when they take as 6 millimeters. So here, this table uses the number of participants and number of studies which have participated in this guideline. There is evidence that the pregnancy rate is less as the endometrium is, when the endometrium is less than 7 or less than 8 or less than 6, but the evidence is low. So even though we say that it is 7 or 8 millimeters, and I'm saying that there is evidence for that parameter or that number only, we have the evidence, because many authors have taken that number as a cutoff and studied, and so we have evidence published for that number only. And when they try to compile that, and they are getting only low evidence, but there is some evidence. But in the low, the evidence is slightly better when you compare patients who get pregnant and people who don't get pregnant. And definitely the endometrium of people who get pregnant is slightly better, at least 0.5 millimeters better when compared to people who don't get pregnant. So thickness does matter. So that's what this guideline tells. After all this many years, so we are still saying thickness matters, does matter. That's all. Okay. So why there is so much problem with this evidence is because it is a hysteroscopy or 3D of the uterus is not universally done. There is so much variability and so much bias. There, just because the endometrium is 7 millimeters on the day you are seeing her or the day you want to give your trigger, and then we don't know the background, what is her age and what is wrong with her uterus otherwise, and everything else, anything can be wrong with her. And we don't know, we're just taking that 7 millimeters or 8 millimeters, try to put them into one study and then see if whatever intervention we are doing, whether it works or not. So there is so much of bias in whichever evidence you are taking. And some people, once there is a 7 millimeters or 8 millimeters, they cancel, or some may proceed with a transfer. Then again, there is a bias. We don't know whether people who there is not many randomized control trials where they're taken 7 millimeters and transferred and not transferred, and not many studies are available in that segment. And some people, everybody wants to give pregnancy to their patients, and they start adjuvants the moment they see their endometrium is slightly small. So that again introduces a bias. And diagnosis is not made. Why the endometrium is thin, why endometrium is not growing beyond 7 millimeters, that diagnosis is not there. We only have that endometrium is 7 or 8 or 6, something like that. And because of this so much of bias, single center studies where they select people and then give some intervention, they show a good, a good outcome with that intervention. And when you try to do a meta-analysis or try to go for other observation studies and supporting studies, you don't have much to support any intervention in this. So the situations where we generally identify a thin endometrium are these: in non-ART cycles like clomiphene or letrozole or gonadotropins, or hybrid like combining everything. On day 12, if the endometrium is less than 7 millimeters, or in ART cycles, in fresh cycles, when you're trying to give the trigger, I'm saying 7, you can say 8, your wish. So that's what evidence is there at. So less than 7 millimeters when fresh ART cycle, and in frozen ART cycles also, you're trying to grow the endometrium and it is not growing beyond 7 millimeters. So these are the situations we find that the endometrium is thin, and then we are perplexed as to what to do next, and why this endometrium is not growing and giving everything under death. This is exactly what I'm saying. This and thin endometrium, majority of the time, of course, sometimes it does happen. Majority of the time, it shouldn't come as a surprise. We should be able to predict it and prevent it, or have an action plan in place. So, we have. Why I'm saying is this, because majority of the time, when we are evaluating the initial evaluation of the couple, the endometrium is not given a lot of importance. Only when we start stimulating and when we face that thin endometrium, or when we start doing an ART and then face when we are trying to transfer and we have a thin endometrium, that is when the endometrium is given a lot of importance. I'm not saying even if the endometrium is perfect, even at the evaluation cycle, it doesn't act up when we are trying to, it does. There is a segment, but there is a significant segment where you can predict beforehand itself, and then try to correct or do something about it, so that we are not even in that situation to begin with. Okay, so we have to evaluate it properly, do a 3D uterus, and the natural cycle monitoring is one thing I strongly believe in. If she's an ovulating woman, try to do, it's always better to have do a natural cycle monitoring. So once we see a good endometrium of 9 or 10 in natural cycle or whatever cycle, then we are sure that the endometrium is good. And then even if one of the cycles, when we are trying to transfer, if the endometrium is not growing beyond a 7 or 8, we know that this endometrium is okay. Only thing is we need to modify the medicines what we are giving, or the agents we are giving, so that we achieve that or go back to nature. Okay, so natural cycle monitoring is very, very important. If she's an anovulatory woman, we can go ahead and stimulate and see, just for the endometrium sake also, to see if that endometrium is all right. And at this evaluation, we have to make sure that endometrium is not the cause for infertility, to certain extent at least. And we should do a proper ultrasound, have a reasonably good transvaginal probe, and measure it in a sagittal plane, thickest portion from basalis to basalis. Leave the lucency and avoid the contraction wave. If we find one, just wait for it to go away. And usually we find this thickness within the first 1 centimeter of the fundus. And of course, it is going to be difficult if there are myomas, adenomyomas, and body habitus is changed and orientation. Of course, we have to have a good machine, and then be patient, and then get some position, and then try to measure anyway. Several studies have shown that there is an inter-observable variability of endometrial measurements up to 1 millimeter. So where does that 7 or 8 or 6 stands? Again, is a question. Why I'm saying all this is because unless we understand the flaws in the evidence, we won't directly just blindly apply the evidence to our practice. We have to understand what is going on with the endometrium in the patient sitting in front of us. Then only we can see whether we can apply the evidence which we learn. Okay, so whenever it is possible, if you have a good machine, try to look at a pattern in detail, volume, and do the Doppler indices as well. And finally, when you do all that, you arrive at 3 types of endometrium. Either it is pathologically thin, or structurally normal, and probably the stimulus was not all right, or structurally normal. You have given enough amount of, you think you have given enough amount of estrogen and whatever, but still it is not reaching to the optimum level. Okay, so these are the 3 types which we have to deal with. So if we can put in the initial stage itself, if we can put our patients into one of these categories, even before we go ahead and stimulate her ovary, we know what to do with her endometrium. So that we don't have to, give her something and then think about it at day 12. Okay, so in the first category is a pathological and or structural damage, or basal layer is damaged, can happen in tuberculosis, repeated curatages, hysteroscopic surgeries, myomectomy, septal resection, postpartum sepsis, endometritis, or radiation. Basically, the basic basal layer is damaged, and there is a lot of fibrotic adhesions inside the endometrium, which is called, of course, as Asherman syndrome. There is a beautiful paper in Fertility Sterility in 2020 about how to manage this Asherman syndrome. Once we see that thin endometrium, we don't have to think that there is no light at the end of the tunnel. We don't know what to do, and we immediately we don't have to, of course we have to be cautious and tell her that it is a lengthy process, and then we need to do a lot for her, and at the end of many months only we'll know how her endometrium is developing. But still, if we can read that paper and understand it, we can help a lot of these unfortunate patients. And they start by classifying, because we need a classification to see to compare notes between the hospitals or between the institutions. European Society into 4 grades, ASRM into 3 grades, and this Donnis classification is the recent one. It's a very easy classification. If you have adhesions in the center, A is thin and flimsy, and B is fibrotic and connective, means strong adhesions, and then lateral adhesions is grade 2, and then if you have only in the cervical area, it is grade 3A, and then if the whole cavity is obliterated with adhesions, is grade 3B. So there are, this paper has taken several authors who study Asherman syndrome in depth, and they are doing a lot of work in Asherman syndrome. This one group in from Stanford, and their policy is, of course, we do a hysteroscopy to determine whether it is simple or, I mean, grade 1, grade 2, grade 3, or something like that. And if it is grade 1 or 1A and 1B and things like that, and can be easily managed by one hysteroscopy, or you repeat the hysteroscopy after a couple of months and give estrogen therapy. But these people, they say that even in the severe grades of Asherman syndrome, you can keep doing hysteroscopy, do the hysteroscopy, release the additions, give estrogen for 3-4 weeks, do the hysteroscopy again, release the additions again. So by this, they were able to achieve 80 to 90% of good cavity and 50 to 60% of pregnancy rate. Of course, this statistics involves all the severities of the Ashermans, but still Ashermans achieving 50 to 60% of pregnancy rate is fantastic. I think there is another group as well, is extensively working from France, means Netherlands, and extensively working in Ashermans. They believe that there should be centers of excellence for to treat Asherman syndrome, because not everybody should, with a hysteroscope, should start treating with the Asherman syndrome. You should know. When there are centers where they keep doing all the time, so they can do a better job and really give a good, reasonably good cavity and a reasonable reasonable pregnancy rate for these people. And they also believe in the Foley's bulb, keeping a Foley's bulb and giving estrogen, and then again doing the hysteroscopy. So repeat hysteroscopies and plus adjuvants like estrogen or a Foley's bulb. So we can do all this to get some kind of a cavity developing there, and then get that endometrium out into some kind of triple line. And the same paper has taken other authors also, has addressed other authors also, who believe that all this while we were thinking that in thin endometrium, if you look for a general evidence, there is no evidence that there is no good evidence to use the stem cells or use PRP or use any of these things. But when you are dealing with a pathologically thin endometrium, there is a good evidence, and there is a lot of papers, and these are original studies, and then they have used GCSF and recruited stem cells and injected into the spiral arteries. But there are several studies where they inject the stem cells into the endometrial cavity, just like that, or subendometrially also. So evidence is building up, and so that they can stimulate whatever small endometrial islands that are there in the very bad endometrial cavity. And we get, they had 3 spontaneous pregnancies. All these are severe Ashermans, and 7 pregnancies after 14 it's fantastic again. So it's not like nothing works for thin endometrium, but if your thin endometrium is because of something, these things can work. Again, there's the original study on PRP. If you look for evidence on PRP, apart from single center studies, we will not have, but these journals publishing original studies about PRP is encouraging. It is not like just a tonic, everybody, people who use it without telling the other center, we don't use anything kind of. But if your endometrium is as bad as, as you perceive it is, and if just giving the estrogen will not, allow, you can't give the estrogen and pray for it to grow, it may not grow. So then there are other things which can be used, and there is evidence for PRP as well. This is for, of course, and this is one thing which I liked in this paper, but I'm going to skip it. Like, it is to prevent and be very, very, very wary of the situations where you will get Asherman syndrome, because we are all fertility specialists. We don't want to damage the endometrium. I'm so scared to do a DNC also. And especially if there is a retained products of conception, I'll never attempt without a hysteroscopy. So something like that. So, you do anticipate. And then after you do a bad, if you remove the retained products of hysteroscopy, products of conception, and if you think that the endometrium is not looking good, you can immediately give estrogen and avoid the additions to be forming. So that kind of stuff. Okay, so it's a good paper. I encourage all of you to read, but I can't do justice if I keep addressing that paper alone. So that is one segment where, thin endometrium, pathologically thin endometrium, you have to really fight and somehow get some endometrium out of it. So the other category is there is no structural damage. There is, the basal layer is intact, but when you give the estrogen, you may not get the endometrium as you expect. So this is one subset where you may have to, you just can't just give estrogen for one cycle and expect the endometrium to grow. You may have to use a lot of cycles to develop reasonably good endometrium. The endometrium over several cycles, like initially also there will be endometrium at maybe 3 millimeters or 4 millimeters in many of these uterine anomalies or premature ovarian failure, where they were not taking any drugs, the uterus would have shrunk, and the endometrium is also not responsive. Immediately, if you go ahead and they agree, they come to you and then they say, okay, I want donor egg, and then do the transfer. If you try to do the transfer the next cycle, you will obviously fail. So you need to develop the uterus and develop the endometrium properly. Even if the uterus size is looking reasonably okay, but the endometrium will take a few cycles before it becomes very friendly to the embryo in these subset. Of course, so like I said, several cycles of estradiol, and in some cases of uterine anomalies, there is a controversial role for metroplasty in a very, very narrow uterine, means a unicoordinate uterus. If you try giving a lot of times estradiol, and if it is not working out, you can do a little bit metroplasty according to several studies. I'm not saying that, and you again give the estradiol, and then you get a little bit broader cavity, then you can go ahead and transfer. So otherwise, unicoordinate uterus, the failure of implantation is quite high. Okay, PCOS also, majority of the time it doesn't trouble us, but sometimes when the androgens are high, and sometimes we see that the uterus is quite small in PCOS patients. I'm sure many of you would have noticed, few patients, not all of them, and especially people with a lot of androgen, a lot of hirsutism and all those things. And there is some kind of altered endometrial receptor profile in the PCO. So from high androgen milieu to, we have to take the endometrium to high estrogen milieu. So maybe we'll have to suppress the androgens, and we give 2-3 cycles of estrogen and try to get the uterus into estrogen, but tilt it into estrogen friendly milieu and something like that, or slowly increase the estradiol. Many a times these PCOS patients, if you suddenly give a lot of, we think that okay, the endometrium is not going to develop properly and there's a lot of androgen, give a lot of estradiol, give 6 milligrams or 8 milligrams to begin with, or 10 milligrams or something like that. But then there'll be just endometrium will grow to 4 or 5 millimeters, then it will stop. That means I think the receptors are all blocked. So there is some receptor problem in the PCOS. So we need to give a slowly increase, like 2 milligrams, and then 3 days later 4 milligrams. We can slowly see that the endometrium is slightly building up. So that slow increase also works whenever we suspect this receptors will, when they get clogged, even if you give more, it will not take up that estrogen, and it will not give that. It will not develop, contribute to the growth of the endometrium. Okay, so that is one set, and this is my last set. Okay, this is where we all concentrate, and we think that the majority of our cycles fall into, majority of our endometriums fall into this, but there is a significant set of endometriums which fall into the previous sectors where we can do something about it. We can develop them. Of course, in this, can we do something about it? Let's see, like fresh cycles when we see, and we are trying to concentrate on the oocytes, and then when the endometrium becomes 7, and when we are trying to give trigger, it is okay, we can postpone. Okay, they or change the type of estrogen. So whichever type of estrogen you are using, try to change into other type of estrogen. But again, there is no guideline or there is no practice points of anything intelligent for me to tell as to why this will work and that does not work. It all depends on that particular patient's endometrial receptivity or receptors. Definitely when you change, you will see some kind of difference, how that endometrium starts increasing. And again, slow rise, I have already told you. When you are doing the slow rise, and once the endometrium becomes 9 or 10 millimeters, don't keep on increasing, because if you keep on increasing, we see that there is some kind of shrinkage of the endometrium also. So it is slowly increased till you get the proper endometrium, and the number of days is also very important. So if we get the endometrium, required endometrium on day 7 or day 8 of estradiol, we shouldn't immediately start the progesterone. That also, the endometrium won't have developed enough vascularity, enough number of glandular cells, so stromal cells in that short period of estrogen exposure. We should at least give 12 days, and people say 10 days is also good enough. And in the evidence, if you see, whenever your endometrium is 7, you can give progesterone, but I don't think that works. And there is a reasonably good evidence which is forming, saying that you need to give a reasonable good estrogen exposure for the endometrium, and we need the thickness also before we start the progesterone. And of course, we can take 2 to 3 cycles to get a perfect endometrium. If none of this works, we have already done a natural cycle monitoring, and we have seen a good endometrium. Hopefully, if we have not seen, we would have done something about it there itself. And because we have seen, we can go for natural or modified natural, even though it is monitoring and transferring is a little bit tricky, but it's okay. We can go for these cycles. So I'll just quickly mention pentoxifillin and vitamin E. These are used 1000 IU plus pentoxifillin 800 milligrams per day, 6 to 9 months. If you are not in the last category and the first 2 categories, you can use these medicines. Tamoxifen gives a better thickness when compared to clomiphene. Low dose HCG also, according to several studies, gives a lot of slightly better endometrium when compared to not giving it. And GCSF, this slide everybody says, and Glacier is the one who said it works, and he's the one who said it doesn't work. So whether you can use it selectively. You used all the estrogens, everything we have carefully planned everything and used everything in our armamentarium. Then if we need a little bit more of vascularity, a little bit more of the endometrium, if we think if we have 1 more millimeter or 2 more millimeters is enough, in that particular patients, we can use all this GCSF or PRP or anything like that. But if we start using for everybody, then we won't have evidence for the intervention. The intervention will be wrong, but it can be used selectively when we are not able to build up the endometrium by in the last extra minute, extra millimeter or so. There's one interesting paper I came across, which we can use growth hormone if it is absolutely not it is refusing to grow. The guideline again, as usual, the guideline says aspirin when in 8 millimeter clinical pregnancy or live birth. The evidence is very low for embryo transfer, fresh or frozen cycle. Sildenafil citrate, it is the same. The evidence is quite low for fresh or frozen cycles. GCSF also, like majority of this thing, because of bias or there is no selectivity, we won't get proper good evidence for using these drugs. But for a selective patient, I think it can be used. The guideline summary says changing stimulation medications, the evidence is weak. Use of adjuvants, evidence is weak. But when you are trying to do a fresh embryo transfer, and if you find the endometrium is less than 8, according to this guideline, you can tell them that you have there can be a negative impact, so I may have to postpone the transfer. Even in frozen cycles also, the evidence is there for that. If it is less than 7 millimeters, we can tell them that we want to do something about the endometrium and come back again the next cycle. We don't want to transfer. So thank you very much for the patient listening. I don't know whether I will shoot my time. Thank you.
Thank you, ma'am. Thank you for your excellent talk. We do have some few questions. Ma'am, what to do if there is spotting while preparing patient for embryo transfer, especially during HRT?
Spotting. Okay, so if you are using, we can look at the endometrium. Some people, when you do the transvaginal scan and if the endometrium is growing nicely, we can just ignore and go ahead. We don't have to do anything about it. If the endometrium is not growing, then there is no response to the type of estrogen you are giving, then change the type of the estrogen. If it is becoming trilaminar and there is some spotting, then that's fine.
And what about the duration of Foley's bulb after hysteroscopy in case of Asherman's?
Okay, so these people, they have used for, I think one study I found for 3 days, and the other study I found it for 1 week actually. Even I'm doing it for 3 days. Only thing is I'm worried about the infection, but the formation of the endometrium is slightly better. Put the Foley's bulb there. They give for almost a week and then give estrogens and then, take it out. So that in that week, they expect that endothelium to grow, without getting stuck to each other. And I found in one study, they use it for only 3 days. And I'm sure there are several studies used for different lengths of time. But I'm comfortable using it for 3 days. So that is my experience.
Okay, ma'am. And as you said, it's always
number 8 or number 9 Foley should be put, not the big one.
Okay. And as you said, it's always challenging to prepare endometrium of POF patients. How do you prepare and how do you prime them before embryo transfer?
So we need to give several cycles of, if the uterus is looking very small, if we go into numbers, probably we can say how big the uterus is, 4 centimeters, 5 centimeters, so something like that. But practically what I'm saying is, if you think that the uterus has shrunk nicely and then she has not been taking tablets or any kind of estrogen at all for the past 1 year or 2 years or so we know that this uterus is not going to respond immediately. So give several cycles of your either Premarin or estradiol valerate with a withdrawal. I tell them take this for 6 months and then come back again. So by then we see a good, nice uterus and then some amount of endometrium forming. And then I'll see if they try one cycle in the sense, give estradiol again and then follow her up on day 12, day 13, like that, to see if the endometrium is nicely coming up and the vascularity is coming up. If I'm not happy, then again 3 more months. So we have to counsel them. If we counsel them beforehand, because you have not been using anything, your uterus is so silent, we need to make it more embryo friendly. It will take time, otherwise if we transfer it is going to be negative. But if we take time, definitely these people, because anyway we are going to do a donor egg, and then the success rates will be fantastic.
And ma'am, you said you do hysteroscopic removal for retained products.
Yes.
And you follow them with their endometrium. So how do you follow them after doing a curettage?
Transvaginal scan. I do transvaginal scan.
You get them the next cycle itself and you assess their.
Yes. I do that. In fact, after removing, it depends on the duration for which the retained products were lying down there. If you do it immediately, you give the pill, and if she's not up, and then immediately within a week, you can see when you put in the hysteroscope, that there is not much of adhesion, and then you can just immediately release all those those products, and then endometrium also will be pink and nice. And they've taken the kit somewhere else, and then 1 month later they come with spotting, and then when you definitely see so much of additions, you have to be very careful, otherwise we can damage the endometrium also. Very carefully you have to release all the products. And in that case, I've after I read this paper, before that I was giving antibiotics and asking them to come back again and then see what is happening. But right now, if it is very bad, I'm giving estrogen for them continuously for 3 months. If I have to release a lot of additions, and then antibiotics also, and then see them after 15 days or 1 month or something like that, to see if she's coming along nicely.
And ma'am, if there is thickness and pattern, sometimes we see endometrial thickness, but we don't see a good pattern. So which one do you pick? So you wait for the pattern, or even if the pattern is not?
Evidence is there for thickness. There is no evidence if you go for evidence, but the same evidence also says that even if the endometrium is less than 4 millimeters, if it is a trilaminar pattern and there is some vascularity going into the endometrium, you can expect some pregnancies to happen. So it is up to us what to take. Okay, for me, pattern is also important, thickness is also important, and vascularity is also important. For it's my this thing. I'm just telling you the evidence right now we have only is for the thickness.
Okay, ma'am. And sometimes in ovulation induction also we see when the follicle comes up and the endometrium will not be ready. So in that case, how do you?
That is the commonest situation we see, and the only thing is we have to, whichever ovulogenic, whether it is clomiphene or letrozole, we have to just wait. Majority of the time, 90% of the time, the follicle will be 18, 20, 22, 24. By the time it reaches 24, or sometimes it reaches 26 also, then you see that the endometrium is nicely going 9 and 10 millimeters. I've seen a lot of good endometriums in clomiphene. Only thing is we have to just sit and wait. So even if we wait and the follicle is reaching beyond 24 millimeters and still the endometrium is small, we have to do an estradiol level to see if that follicle is good enough, if it is producing enough estrogen. So if that follicle is producing enough estrogen, the estrogen is more than 200, and then you have a thin endometrium, then you start suspecting endometrium and do whatever I've told you. Try to put it into one of these categories, do a hysteroscopy to see if there is an endometritis or some kind of Asherman's. Mild Asherman's can be missed with the scan, just the scan. So you have to put an hysteroscopy and then look at it. So then you can start blaming. Otherwise, if the estradiol is less, then we have to blame the oocyte. Oocyte is not producing estradiol, so that means it is a bad oocyte. So what to do? We change to either gonadotrophins or next cycle add gonadotrophins and all. But there is right now, if you are giving clomiphene and we know that there is some receptor issue with the clomiphene, and the follicle is growing nicely, endometrium is also okay, but you would personally want the endometrium to be a millimeter or 2 thick. Then from day 7, day 8 onwards, again, initially we were giving estrogen, then it was trashed, and then now again the evidence is building up to give a little bit of estrogen, along with clomiphene and along with estradiol produced by the follicle. The estradiol you are giving also will help for the endometrium, but you should not dump the estradiol, little bit of estradiol. So that the evidence is coming up. I'm not saying I have not started using it, but I did read some papers about it. I strongly believe that it's okay. Once the endometrium is it's 24 millimeters, and if the endometrium is 7 or 8, and if there is some vascularity, I don't want to give more estrogen and increase the built up, increase the thickness. I somehow I didn't. It's not agreeing with me, so I'm not doing it.
Okay, ma'am. Thank you so much, ma'am. Thanks for patient answering for our questions also. Thank you so much. It was wonderful. I hope you all meet the challenges with thin endometrium henceforth. Thank you, ma'am.
Thank you. I'll stop share.
Yes. So now we'll move on to our next session. So we have our next speaker, Dr. Madhupriya, who is going to speak It was about endometrial receptivity array. And she's very, very enthusiastic because when we invited her for a talk in Triple M, she was very happy and she feels this like her, motherland. And so she is very, very active academically also. And her keen interest is on poor reserve and for ovarian reserve and poor sperm reserve and oncofertility. Over to you, Dr. Madhupriya.
Thank you so much, Dr. Geeta. Good afternoon, everybody. At the outset, let me thank the IRM Triple M team and my beloved teacher, Dr. Kundavi ma'am, for having given me this opportunity to talk in the CME Endo Embryo talk regarding the ERA. Thank you, Dr. Geeta, for having given me the topic endometrial receptivity array. How far are we? So let us dwell to see how much of knowledge the scientific evidence has given us so far about the ERA, and are we right in using this armamentarium? And what has cropped up recently in the evidences? Is it against or for the use of ERA? As far as the window of implantation is concerned, we know that implantation is a complex process, and we have a long, complex way to know completely and decode the whole process of implantation. Despite so many randomized control trials, despite many meta-analysis, systematic reviews, and many researches which are ongoing for the past more than 2 decades, to crack the nutshell of the complex process of implantation, we still are not anyway nearer. So coming to the decoding of implantation, let us see how far we know about this complex process. With the advanced scientific technologies, with genetic coding, with genetically engineered animal models, we are able to only identify that implantation is a highly organized and a complex process. It is involving many cellular networks which are critical for the function and many molecular pathways which undergo periodic changes to adapt to the implantation process with appropriate hormonal signaling. Now, when we see about the implantation, we all know that there needs to be a unique crosstalk between the embryo and the endometrium, and particularly in a very small time period or time interval called the window of implantation. This implantation window is usually day 20 to 23 of an idealized 28-day cycle, or roughly 5 to 10 days after an appropriate LH surge. Any implantation that happens after the window of implantation is crossed, there are many studies which vouch for increase in the miscarriages, which are both preclinical pregnancy losses as well as increase in the first trimester miscarriages. So, to orchestrate the process of implantation, as the picture is, so is the process, very complex. It involves a lot of molecular pathways to be signaled by appropriate mediators, which include leukotrienes, growth factors, the prostaglandins, prostaglandin inhibitors, various adhesion molecules, matrix degenerating enzymes, and their inhibitors. So each step of this process of implantation needs to be decoded for us to identify an ideal add-on solution or a test or a diagnostic tool to say that it will solve the problem of implantation. But so far, we have not had an ideal solution for the implantation failure, because the complex process of implantation is not completely decoded so far. So what has the scientific evidences told us so far are that the uterine endometrium needs to undergo genetic and molecular-based, cellular-based changes periodically under the influence of two good hormones, estrogen and progesterone, which culminates into structural remodeling and functional remodeling to open up and imbibe the embryo during the process of implantation. And again, with the introduction of advanced omics technologies, especially the targeted proteomics, it is possible for us to identify the window of implantation and also give an appropriate genetic profiling and a specific transcriptomic signature for an endometrium at a particular part of time, and clinically identify the window of implantation and put the embryo back into the uterus at the right time, at the seemingly right time. So all these started when the Spanish doctors initiated ERA as a diagnostic tool in 2013, when they suggested this as a diagnostic tool to identify the window of implantation using many genetic profiling techniques and also by identifying the specific transcriptomic signature of each endometrium, whether they are receptive, non-receptive, pre-receptive, or post-receptive, they seem to have a specific transcriptomic signature which can be identified through the advanced proteomic technology. So they claimed that it is possible to identify the window of implantation and personalize the embryo transfer according to the ERA report in the consecutive cycles. Evidences poured in initially in the initial decades, which supported ERA and suggested that yes, it is able to increase the implantation rate in the forthcoming or the consecutive cycles of transfer when compared to the histological dating of the endometrium, which was done by then. What about the present evidence? Recent evidences in the recent decade has suggested that there are no significant differences as far as the implantation rate is concerned in the general infertile population, as well as no difference in the live birth rate between those who have undergone ERA or those who have not undergone ERA before the next transfer, and also between two subsets of people who have undergone ERA with a receptive status and those who have undergone ERA with a non-receptive status but still underwent transfers to have live birth rates. If there has been no significant differences between the live birth rate among those who were receptive and among those who were non-receptive as far as ERA is concerned, then we have to question the validity of ERA. The same has been done by the HFEA, which has given a red dot to ERA, suggesting that it is not an ideal add-on solution for those with recurrent implantation failure or recurrent pregnancy losses. Similarly, Cochrane has also not given a go-say for ERA as a diagnostic tool in recurrent implantation failure. So, ERA is now not used. There is no green signal for its use because there are two things which needs to be satisfied by any add-on solution which is suggested to the patient as a diagnostic tool. Number one, it has to be proven with various studies that, like a RCT, that it is valid and it is able to increase the IVF success or the outcome in terms of live birth rates. Number two, it should be able to give more than or equal to 10% difference or increase in the live birth rate when compared to the live birth rate due to a routine IVF or ICSI cycle. Similarly, cost-wise,
there should be less than or equal to 10% of the cost involved when compared to one round of IVF or ICSI cycle cost involved. ERA hasn't fulfilled any of these. There are no RCT trials so far suggesting ERA as supporting ERA as a diagnostic tool. There has been no increase in the efficacy or the success rate, and there is no decrease in the cost rate to less than or equal to 10% of what an IVF cycle is. So, those suggested as an add-on solution to patients incurring recurrent implantation failure or recurrent pregnancy losses, ERA couldn't withstand the test of time because there was no difference in the live birth rate or the implantation rate when generally applied to the infertile population for those who have been ERA receptive and those who are non-receptive. Many initial papers, though, had supported the use of ERA. The success rate was proven to those people who have had recurrent pregnancy losses in the form of implantation rates and not in the form of success rates suggested by the live birth rates. And no RCTs have been suggestive of use of ERA as a diagnostic tool as well. Thirdly, ERA had claimed that it is able to identify the window of implantation, but there are still certain questions which are unanswered by the papers. Whether ERA is representative in the consecutive cycles as well, whether the window of implantation of the same person remains unchanged in the consecutive cycles for us to apply the ERA result, and whether a hormonal manipulation in the consecutive cycles are going to affect the gene expression, and if so, how much of gene profiling would be altered, and how much of changes would happen in the specific transcriptomic signature, and whether this is going to differently change the results even when ERA is explained. Now, though molecular dating using the ERA has been able to better the implantation rates in a subgroup of people rather than the histological dating of endometrium, which was done as an old-fashioned, it is still not known how many genes have to be undergoing gene profiling, how many genes needed to be tested to suggest this as representative in the further consecutive cycles, and whether the blind cell collection from the endometrium, is it standardized and is it representative, is yet to be defined. So with all these limitations, we've got recent evidences in the form of one and only RCT done on ERA in 2021, the meta-analysis, systematic reviews, and two important observational cohorts which came up in 2021. The tip is balancing against ERA. Researchers have shown that there is no increase in the general implantation rate, or there is no increase in the live birth rate when compared to those who have been ERA non-receptive or who have not had an ERA before the next transfer. So this places us in a position where the validity of ERA is still questionable. Though ERA is beneficial in small specific subgroup of people who have had previous implantation failures and have narrow window of implantation, it is not clinically useful as an umbrella to enclose all the general infertile population per se. Also, ERA lacks independent validation studies to promote it as a valid diagnostic tool or an add-on solution to those with recurrent pregnancy losses or recurrent implantation failures. So the take-home message, as far as a physician or the clinician is concerned, it is important to continue checking on to a validity of a diagnostic tool before it is being implemented onto the patient. And it is important to make sure that this tool is able to increase the live birth rates at least 10% or more than what is normally expected. And to the patient, it is important to send a message to have patience, and it is more chances that it becomes negative, an embryo transfer, than positive, because we have less than 50% of implantation receptivity, even with a good endometrium, even with a good embryo. So the time-tested fact of trying at least 3 to 5 transfers before encroaching onto the unknown territory, unproven solutions, among which ERA is one. That brings me to the end of this presentation. Thank you very much for the opportunity given.
Thank you, Dr. Madhupriya. Thank you so much. Thank you for showing us on both sides of the evidence about ERA. We just have as you said, ERA is indicated for RAF from your talk. Can you just tell us ERA in thin endometrium? What is your say?
Okay. ERA per se is a tool which depends upon the biopsy of endometrium. So as long as we prepare the endometrium, it has to be prepared in the same way as we do an embryo transfer. So for an embryo transfer, scientifically, as far as the Applebaum scoring is concerned, there are few things which need to be identified. One, the hormones need to be in place. It has to be a downregulated cycle if we are going ahead with the hormone replacement therapy. Plus, there has to be a particular thickness of the endometrium, the pattern of the endometrium, which needs to be triple lined, and also the vascularity, which has to be at least zone 2 to zone 3 for it to be more receptive. This endometrial receptivity array is done only in people who have very good endometrium as far as the ultrasound is concerned, but still have not been having implantation, or in people who already have some medical disorders such as the Asherman's, or people who have thin endometrium, or people who have a pathological endometrium such as endometritis previously, or tuberculous endometritis previously. In such people, it is only done to make sure that it is not non-receptive. So in thin endometrium, it is important to identify that there are no infective reasons. There is no endometritis still lingering onto the basal endometrium, and to make sure that it is not non-receptive. Non-receptive endometrium, though we understand from the recent evidences that there is still a possibility, once we transfer the embryo, there is still a possibility that it goes until the live birth rate, even with a non-receptive endometrium as suggested by ERA. It is one of the armamentarium which tells us to counsel the patient who has had a pathology earlier to say that they have got a very, very minimal chances of success when compared to normal population with a good endometrium and a receptive ERA.
Okay. And one more thing, when we get results of ERA, sometimes we do get some suggestions also about the dosage of progesterone, how much we need to give. Do you think that has got a lot of impact when we go for a transfer next?
Yeah. Most of the ERA reports don't suggest about the progesterone. It just tells you about the number of days you give them exposure to the progesterone, whatever be the amount. Either it is just 200 micrograms of vaginal micronized progesterone that is given for 5 days or 6 days, or it is an oral progesterone that is given for 5 or 6 days. Irrespective of the type of progesterone given during the ERA, it just suggests us to give the same in the personalized embryo transfer time as well, so that we replicate the same hormonal profile in the next cycle as well. But depending on the genetic profiling and the transcriptomic signature which the proteomics gives us, or the transcriptomics give us, that signaling can tell us if it is a little earlier or a little later, starting from even 6 hours, 12 hours, 24 hours to up to 72 hours, delay or prepone the transfer. Because either the progesterone given to the endometrium and the endometrium, which is already ready, is ready only after some time, or it has already become ready and your time is going past. So it only tells us about the time. The progesterone exposure remains the same. It helps us to curtail the progesterone, increase the progesterone, exposure, but not the dose as such. Dose is just the replica of what we do in the ERA. The same is going to be used in the personalized embryo transfer cycle as well.
Okay. Thank you. Thank you so much, Dr. Madhu.
Thank you very much. Thank you so much for the opportunity given. Thank you.
So we'll move on to the next session, panel discussion. So we'll start with our panel discussion. And I think we do have I would welcome our panelist today, Dr. Shweta Mittal from Delhi. She's senior consultant from Gangaram Hospital. And we do have Dr. Raju Nair from Kerala. He's director and head of reproductive medicine from Mitra Hospital, Kottayam. And then we have Dr. Divyashree from Bangalore. She's medical director at Genia Fertility Center, Bangalore. And we have Dr. Noshin from Craft. Welcome, everyone. So I think without wasting time, we can start a session. We are already running late.
1 minute, Dr. Geeta. I just wanted to introduce you. Geeta is a consultant of IRM Madras Medical Mission, and she's in charge of the FNB program and a very tough examiner too. Over to Dr. Geeta.
So let's start our session. So we do have our first case today. So first case is 32-year-old who has got irregular cycles, was married for 4 years. HSG showed bilateral patent tubes. She has got history of 3 cycles of IUI, which was failed. Her AMH is 2.4. Husband semen analysis was normal. So she was scheduled for IVF. Her total AFC count was 15. She was scheduled for ANTAC protocol and then retrieved 10 oocytes, out of which 7 fertilized and had 2 blastocysts. So she was taken for a frozen embryo transfer and prepared her with HRT, and 2 blastocysts was transferred, following which beta HCG was negative. So what next for her? So can anyone take up this question? Do you like to do any investigations for her now, for this patient?
Well, I can just start that. I just want to, am I audible?
Yes, ma'am, yes.
So I just want to do a very quick and a very normal check that how was the mid-cycle endometrium. If her mid-cycle endometrium was good, I don't think I'm suspecting, because just with 1 failed embryo transfer cycles, I don't over-investigate the patient. We know that we are not dealing with tubal factor, we are not dealing with hydrosalpinx, and the semen, I think, was normal. So in this particular case, I would just see that the survival of the embryo was good. So I'll have a 2-way conversation with the embryologist. If they say that the survival of the blastocyst and the expansion of the blastocyst was good, and her mid-cycle endometrium is okay, then just with 1 failed embryo transfer cycle, I don't want to over-investigate. If she still has more embryos, and because she has irregular cycles, so it's not even that I can think that I can do a natural cycle transfer. Had she been a regularly ovulating girl, then I would have thought of a natural cycle embryo transfer for her.
Okay.
Dr. Geeta, patient.
Can I
In
add
this
on?
patient,
Yes, yes.
Yeah, actually in patient, since there are no embryos which are frozen at the moment, I would want to know why only 2 blastocysts. For example, she got 10, if I'm right, 10 oocytes, out of which 7 fertilized and only 2 blastocysts. So there is a drastic decrease in the numbers, whether it is in terms of AFC to the number of follicles, ultimately to the number of blastocysts, there is drastic decrease. So we have to analyze why she didn't get good blastocyst conversion rate. This is what we need to do, because anyway, she doesn't have any embryos which are frozen for subsequent transfers. So she has to go through 1 more IVF. So before going through 1 more IVF, we need to look at things like why it didn't reach a blastocyst stage, whether it is in terms of kind of stimulation, or it is in terms of the semen parameters, or what happened in the lab, what happened in the embryology lab, in the sense like how many got fertilized, how many got cleaved. Even if it is cleavage, whether the cleavage was regular, whether all the blastosmears were equal in size or they were disproportionate in size, what was the quality of the blastocyst. This is the case study which we need to thoroughly investigate before we embark on next IVF, is what I would want to comment on this.
Does she have more blastocysts still frozen, or are these the only ones?
No, ma'am. Only she had only 2 blastocysts which was transferred, so she doesn't have any embryos left.
Okay. Dr. Geeta, I would like to start from the very beginning. You mentioned that she's having irregular cycles. So from her AMH or from the AFC, it doesn't look like she's a PCO. So am I audible?
Yes, you are.
Yeah. So I want to know why she's having irregular cycle, whether there is any hyperprolactinemia is there, or whether she has any thyroid dysfunction. So the baseline evaluation, I would like to have an extended baseline evaluation. And then, as Dr. Divyashree and Shweta ma'am said, whether a woman with 2.4 AMH, what was the starting dose, whether the starting dose was adequate, how the response was going, and what was the fort and what trigger. And as everyone has rightly mentioned, the number of blastocyst formation was less. So what about the sperms which were injected? What about the oocyte quality? And also again the previous panelist was mentioning, the lining during the preparation, or whether there was any difficulty during embryo transfer. So all these parameters will let us help us in understanding better and will prevent the further mishap.
Yes. So analyzing her. Yes, sir. Yes.
My thoughts.
Yes, sir.
Yeah. Basically, what all other panelists said, I do admit that. But there is one important point I'd like to highlight, because we just a report of 2 blastocysts. How healthy or how good the blastocyst. That either a pictorial description or whether it is expanded blastocyst, how was ISM, how was the trophic redo. So all this information is quite crucial, rather than just saying just put back to blastocyst. Well, if you have a majority of time such a patient comes to you, maybe to another IVF center with this report, we always try to get in details about the blastocyst quality, because when an embryo fails, majority of time the problem will be lies with the embryo rather than other things. So how that embryo is evolved, that is why all the other panelists are putting their thoughts on. But this all starts with your embryo. If just putting a blastocyst and it is really a bad blastocyst, then the answer is obvious there. So I think the most important thing is we should give a detailed report of not just mentioning blastocyst, how good was a blastocyst.
Yes. So to adding on with her analyzing her previous cycle with what was the dose and how she was taken up for full stimulation, and baseline evaluation, as you said, thyroid, prolactin, and then looking at the grading of the embryo and how was the embryo. If possible, if we have a picture, still better. What about if at all we are scheduling her for next IVF? So do you like to go ahead with an endometrial scratch, these type of patients?
Not at all. The latest.
Personally, don't do it. Yeah.
Yeah. The latest article published in NEGM by the scratch trial by Lenson et al. Has clearly shown that the scratch is no more beneficial. Though, we for 10 years, for the past 10 years, we've been doing it, trying to remodify, doing it in the luteal phase, doing it in the follicular phase, but none helps.
Okay. What about hysteroscopy for patients with previous IVF failure?
Hysteroscopy as a routine should not be done. I mean, again, there are a lot of evidences supporting that, it is not going to be of much help unless it is repeated failures. And you are suspecting something like chronic endometritis. Only in those cases. Just with one failed IVF, as I told previously, we have to work more on the stimulation. We have to work more on the embryology aspect rather than investigating on anything, whether it is endometrial scratch or further investigations or hysteroscopy doesn't have much role here, because previous stimulation itself, it will act as a textbook for you for that particular patient. So we get a lot of information from the previous stimulation. So I don't think so we need to do anything extra.
Yes.
Can I add on?
Yes.
I would like to quote some evidence. So earlier we were tempted to do hysteroscopy after IVF failure, but with the a publication of Insight trial, where they have done hysteroscopy after previous phase for a routine hysteroscopy prior to IVF, or with the trophy trial, where they have done a hysteroscopy for RIF patients and the control group did not have hysteroscopy. The study showed that there is no difference. Again, these are also publications from very good reputed journals, which help us backing up the idea that there is no need for routine hysteroscopy if the 2D scan or the 3D scan is normal.
Yeah. Yes. So this patient, she had an antagonist protocol. So that is what the information we have. And we don't have the exact gonadotropin dosage, what was given and anything. So if we are scheduling her for IVF now, do you want to change the stimulation protocol now? Or what would be the choice of protocol now?
I think in this particular case, the only thing I would do is that I would give a luteal phase estrogen, hoping that the cohort is a little better. However, and a standard dose, which is 225 units starting dose. I would give a mono, therapy, which is a recombinant FSH, which I know gives a good batch-to-batch consistency. And I would not like to add an LH in this particular case, because I'm not suspecting one odd cycle can have lower embryo conversion. That doesn't mean that it will always have it. But since she's an unexplained infertility all the while, we know that, in so many cases you find oocyte issues. So I don't think if my first stimulation was good enough, I'm going to achieve something great. So just these little bit minor changes maybe may help. Unless the embryologist said that oocyte quality was very poor, and nowadays I add CoQ enzyme for 2 months. Otherwise, I don't do.
So, ma'am, you synchronize the cohort usually for all patients, or?
No, I don't. So many patients, they come on day 2 itself to start their cycles, and we just out and out start. So if I see the number of oocyte 10, it qualifies in normal responder, not even suboptimal responder. So though the AFC was a bit more, 15 reported, we don't know whether we'll be able to achieve more, but I think a 225 starting dose should be good enough, and possibly a luteal phase estrogen can, kind of make the cohort better.
Sir, you want to add something in this case?
No, I think the stimulation part is quite satisfactory because we got an adequate number of oocytes. But unfortunately, Dr. Divyasri has told from the number of follicles reaching up to the blastocyst has tremendously reduced. So basically, before changing over the protocols of stimulation, I would like to put my thoughts on why this fertilization issue has and the further cleavage issue has happened. So there will give much light to it rather than just changing the stimulation.
Okay, so any choice like recombinant, no need to use recombinant, HMG, or
basically I still prefer recombinant FSH for majority of my cycles, but all the evidence suggests that HMG and recombinant FSH is more or less equivocal. But I feel it's a personal preference and more batch-to-batch consistency with recombinant FSH, so I prefer that.
Okay, so trigger-wise, anything specific? Dr. Divya, you want
to understand how many mature oocytes did we get last time? 7 oocytes is what we got, but as I told you repeatedly, we just got 2 blastocysts. Is it because we just got 2 mature oocytes, or is it because we got good oocytes but still 2 blastocysts got converted? If there is very less number of M2 oocytes, that means there is something wrong either in the timing of trigger or the choice of trigger. But if the M2 rate is good, which is probably 80 to 90% of M2 conversion, that is good enough. I don't think so we need to change anything either in stimulation nor the timing of trigger or the trigger itself. But if there is drastic decrease in the number of M2s what we have got, then definitely we should rethink about the timing and the kind of trigger what we give.
Okay. So coming over to her endometrial preparation, she had HRT protocol previously. So, and with irregular cycles. So any other option now for her, or we'll go with HRT?
See, as what I feel, once it's a phase doctors, more than patients, we get agitated or we get worked up a lot of thinking that why it failed, and we want to add everything under the roof. But that's not the way a doctor of reputed practice should think like. We also have to understand every transfer will give us the maximum probability of pregnancy is only 50%. So just because one transfer failed, that does not mean you have to add on low molecular weight heparin steroids. When it comes to steroids, let us understand implantation is akin to inflammation. So there is some kind of inflammation which is going on during implantation. So if we give steroids and bunk down the inflammatory process, in fact, we are doing more harm than good. And even in terms of low molecular weight heparin, there are enough number of evidence to suggest that it is not going to improve the probability of pregnancy. So as I'm telling you again and again, we have to work on the stimulation. We have to work on the gametes rather, that is the egg and the sperm and the embryo. Because majority of the embryo transfers fail. That is 80% of the embryo transfers fail because of embryo issues. It is very unlikely to have an endometrial issue. If we have to have an endometrial issue, it should be definitely repeated failures. So any first transfer, if it fails, it could be just because of the probability, that is just 50% wherein she's lying in the other 50% that she didn't conceive, or it is a serious issue with the embryo. So we have to work on the embryo rather than giving add-ons, whether it is clinical add-ons or laboratory add-ons. I think we should resist using them as a routine.
Yes, completely agree. For this scenario,
so there are two protocols which are used for these patients. Generally, in an irregular cycle, when I know that they are not ovulatory, I would prefer an HRT because more easier. The second one is that, yes, sometimes I use low dose gonadotropin.
Ma'am, you're not audible. So you want to add something regarding this using?
Actually, I endorse what all Divashri has told because it's perfect answer. Because our aim should be to focus on the embryo and the gamete and the embryo development. All other add-ons are, I think, we are panicky in getting a result. That is why it's not evidence-based.
Yes. So yes, so here this case doesn't have much value on add-on, I feel, and we need to concentrate on an embryo factor and go ahead. So moving on to the next case. So this case, she's 32-year-old with regular cycles, married for 3 years, husband 36-year-old. Semen analysis showed total count of 3 million, and total motility was 20%, morphology 1%. Karyotyping done for husband, which was normal. And female, she had AMH of 2.1, AFC was 10, and she was scheduled for IVF. Antagonist protocol, oocytes retrieved were 8, injected 6, out of which 5 fertilized. And she had 2 day 3 grade A embryos, which was 6 to 8 cell. And she had a frozen embryo transfer, which was through HRT protocol, and beta HCG was negative. So what next? What investigations for male? Anything further?
Yeah, the obvious answer is look for the sperm quality by sperm DNA fragmentation. Because in this patient, even though we got number of oocytes, on day 3, where actually the embryonic genome get presented, we are getting lesser number of embryos. And those embryos were grade A quality as per the description, but the fertilization and after cleavage was not that expected. So whether the since the count is to 3 million with the morphology of 1%, whether we picked up the best quality sperm to get fertilized is a question of to be debated. So in that scenario, a possibility of sperm DNA fragmentation being high in this patient is quite possible. So doing a DFI will be a better help for this patient.
We would like to do physical examination, rule out any varicocele, and also do some hormones, FSH, testosterone, and prolactin, thyroid if possible. And I think the workup should be over if we do all this, and the sperm DFI as Sir said.
See, I have a point to put. The main role of sperm is to fertilize the oocytes. And out of 6 oocytes, 5 got fertilized. And none of the embryos, even though there were 2 embryos, had fragmentation. So basically, the sperm has done the job. The sperm has done the job. I am not blaming even this 1% morphology, because no matter what we do, the morphology kind of will not change. The identifiable causes, yes, we can find. But in this particular case, I think if we could have gone to blastocyst, or maybe in the next cycle, we will be able to see which are the arrested embryos. There is a possibility that after day 3, these embryos could have gone into arrest and we could not identify it because we did a day 3 transfer. So this is how I would put it.
Okay.
There are two things which I have to add on here. As we said, 5 fertilized, but only 2 8-cell grade A. So what happened to the remaining 3 embryos is the other details which we have to understand. For example, it has got arrested. Say it has got arrested. At what stage it got arrested? Is it at PN stage? Is it at 4-cell stage? Is it at 8-cell stage? Is what we have to understand. Because with this, we get to know what is a major contributing factor. Yes, as Dr. Shweta said, 2 embryos have done their job. 2 8-cell grade A have come. But what happened to the other 3 embryos? So in general, we get to understand in this particular cycle, what is the thing which has gone wrong? Is it the sperm factor or oocyte factor? So definitely embryo transfer has failed, so it is embryo factor. But if it is an embryo factor, is it a sperm factor or an egg factor is what we have to understand. So if it is arrest before 4-cell stage, probably we should think more in terms of sperms. But it is beyond that, which we get to know only if we culture them beyond 8-cell stage. Then we also get to know whether it is combination of just a oocyte factor or a combination of just the embryo factor. And apart from this, when we speak about DFI with 3 million count, I doubt that whether if embryologists are also there in the panel, whether we'll be able to do DFI with this, because to assess DNA fragmentation, we have to have good number of sperms. So either we have to assess the DFI by pulling in the samples, or with just one sample, I think it would be difficult. And just because the DFI is normal or abnormal doesn't always say that, okay, it is completely sperm factor or oocyte factor. So as I told it, you have to study the chronology of events during the or the embryological events which lead to a blastocyst formation. That is when we get to know more things about this particular case.
Dr. Divyashree, DFI is only required if there is a clinical varicose. It's not otherwise required. And as you said, 3 million is difficult to pull.
Yes, exactly. So DFI as a first thing, I would not probably suggest, because it is practically difficult. And even if we go by evidence, whether DFI has an impact on the early cleavage or implantation is still controversial. So how far DFI is going to help is still a question.
My embryologists, they always say that the best way to select the sperm is under the micromanipulator machine, because it's 400 times enlarged. And definitely in these kind of cases, the expertise of the embryologist holds true, because it comes with experience which sperm to choose. No matter if it's an internal packaging defect also in DFI, it will not be overcome in the next cycle or any of the cycles. It's only the storage, toxicity which you can overcome with antioxidants. So DFI really in reality has a little role. What we need to see is the blastocyst conversion in this particular case, I personally feel.
I think the debate is going a little out of phase, because the function of the sperm is just not to get it fertilized. By means of ICSI, we are getting the sperm into the oocyte and the nuclear fusion happening, that's all. But afterwards, the further cleavage, the mechanism of the sperms and the oocyte, both are actually important for going up to say day 3. So previously there is a concept called embryonic genome activation. So we all learned that this embryonic genome activation happens by day 3, from 8-cell embryos onwards.
4-cell stage, yeah.
Yeah. So till that time, actually the maternal factor is actually the predominant one. So from that time onwards, the male partner involvement is actually coming into play. So definitely, just for a pronuclear phase, the sperm, the process is over. I think is just hard to believe for me.
The thing is that when you have a clinical suspicion, the current recommendation is to do DFI. I understand that the DFI has a lot of issues. One is that there are different types of testing and there is no standardization, and also you need it cannot be used for the current ICSI cycle. But having said that, the SRA 2019 guideline for recurrent pregnancy loss suggests doing DFI for the purposes, and also even for the recurrent implantation. I wouldn't suggest that for this particular case, as that if there is no varicocele and the other examination is normal. But if it's a recurrent implantation failure, they suggest doing it not for the increasing the pregnancy rate. This is mainly for the prevention of for the health of the future children, because it is correlated, as Raju sir said, it is more for the functional benefit than just the mechanical benefit.
That's the reason right now she doesn't qualify in
right now she doesn't qualify.
RPL is very early unexplained pregnancy losses.
Yes.
Where you just cannot explain any reason, and especially when they're having repeated biochemical kind of pregnancies, then yes, we should think of DFI. But in this particular case, just because the semen parameter is inferior, somewhere I do not see an importance of DFI, because how will we treat it? Again, the same sperms will be there. Again, you will be resorting to ICSI. So the only thing I think is very short duration of abstinence is important. In these kind of cases, just 1 day of abstinence and then ask the male partner to ejaculate. This is a very important instruction, and we need to see that he's not a heavy smoker.
Yeah. See, Shweta, what all you're telling is actually basically the steps to decrease DFI, isn't it? So if you have a data on what is a DFI, will it definitely helps in screening and explaining to the patients of importance of 1 day abstinence and avoid smoking, all those things? Because DFI is the one thing which in your mind, by counseling that you should have only 1 day abstinence and avoid smoking.
Because SCD is a very, not a very superior method of screening, and gives a very, very false, I think, positive or a very high DFI rate, and we start treating them incessantly with antioxidants. Whether they make any benefit or not is very, very doubtful. So that's my point.
Okay. So what if DFI is high? So if at all you want to give antioxidants?
Then it will be antioxidants.
Yeah. So
antioxidants treat the underlying cause. I mean, as I was saying, I would do DFI only if there is clinical varicocele. So if there is a varicocele, I would correct it, and antioxidants. And obviously, they have already undergone ICSI. ICSI would be the chosen method again.
Okay.
Now, should I have a doubt about the statement of you will do DFI only if the varicocele is there? Because it should be reversed now. If the DFI is high, one of the causes of increased DFI is varicocele, because it can be due to any number of cases. So if you putting a statement like if the patient is having varicocele, then I will check the DFI. If it is high, then I will do surgery. Because the indication for varicose surgery is almost evident, and it is actually equally considered by all the societies, because which all patients actually need a varicocelectomy. It is absolutely not based on the DFI.
Absolutely, sir. I want to clarify on that part. What I meant is, if there is a clinical varicocele, then I would do DFI just to actually, because it will help us in counseling the patient whether he needs a surgery or not. Obviously, only clinical palpable varicoceles require surgery. And in this case, if we are suspecting it, I would definitely do it.
Okay, so what are the other indications where you opt for DFI, if not this patient? And if at all not patient not having varicocele, what are the other indications in clinical practice where you ask for DFI?
As sir mentioned, age more than 40, smoker, then varicocele.
Recurrent pregnancy.
Yeah,
recurrent pregnancy loss and recurrent implantation failures are also indications to measure DFI.
What about diabetic males, obese males?
Yeah.
Okay. Can be done.
Recurrent
any medical comorbidities also actually will come under the picture, especially when someone was on antipsychotics for long. So any medical condition also will fit into the criteria. Debilitating condition.
Advanced paternal age is also a criteria.
Yeah, age more than 40.
Okay, so if these patients, when we give antioxidants, what is the duration? How long do you give antioxidants in case of high DFI?
For 3 months initially and repeat the DFI. So we personally like to do SC-SA test. We believe more because it's a more quantitative assay, more than SCD.
Sorry, can I add on?
Yeah.
Coming back to what I was telling Raju sir, it got interrupted in between. So what I was saying is, I do send sperm DFI testing, because in case if the count, if the sperm DFI comes out to be normal and the patient is not willing for the surgery, I know it is not very much recommended, but we would do some sperm selection methods like MAX or microfluidics. While if the patient is willing, then definitely surgery would be the best. And if the sperm DFI is high, definitely that can help us as a prognostic tool.
So our experience is that in severe oaths, none of the sperm selection technique seems to be working, because PXC dish, they don't bind the sperm at all. So, they don't get bound to hyaluronal beads. The microfluidics fails to, separate out the DNA integrated sperm. So when we are dealing with severe oath, it just comes to, again, by clinical experience, picking up the right sperm by an experienced embryologist and doing an ICSI without any paraphernalias. Just shorter duration of abstinence seems to work the best for us.
I agree with ma'am partially on that. It's quite a controversial statement, and even the evidence is also not that much backing up. I think the hyaluron-based ICSI, the publication of 2016, which was published in Lancet, actually said that the pregnancy rate doesn't matter with the hyaluron-based ICSI or not, but it said that the miscarriage rate was significantly, in fact, half reduced. And
yeah,
subsequently,
I was referring only to cases of severe oaths when there are like less than 1 million count.
Okay.
It sounds rosy, but none of these techniques work because the sperms just don't get bound. So that's a technical challenge. That's what I was saying.
Yeah. So what about the other sperm selection methods? I think now most of us are happy with ICSI and our embryologist. So any message for our audience regarding other sperm selection methods? Though evidence is not great supporting these methods, I think.
Currently, HFPA has put red light for PIXI and MC. The only one which is in the gray area is MAX.
MAX, yeah. What about your experience with MAX, Dr. Noshin?
That's what I'm saying. We in these kind of cases where the patient is not willing for surgery and we want to choose the best one, we do MAX. We have done an offhand analysis where we have done sperm DFI testing on those MAX samples. Obviously, we can use them for ICSI, and we found that the sperm the DFI was actually lesser. But again, then there comes to the the question whether DFI actually is really important or not. So it's all like a gray zone at the moment. So, but then for a difficult patient to counsel, I definitely difficult patient who's not willing for a surgery for a varicocele, I do MAX.
Can I say something?
Yes.
Yeah.
Yes.
See, one thing, as we are discussing investigations after investigations, one thing what we have to realize is the probability of pregnancy with every embryo transfer, which is 50%. Though I'm telling this repeatedly, but this is a very strong point which we have to make. Just because one IVF failed does not mean that she or the couple have to go through repeated investigations. Repetition is the key to success, whether it is natural conception or timed intercourse, IUI, or in fact, even IVF, which means we have to do repeated embryo transfers to look at a cumulative pregnancy rate. So as clinicians, we have to understand 1 or 2 IVF failures are still okay, provided all the parameters are in place. But if there is any problem in terms of how many embryos we got at the end point, we have to go back on and work on our stimulation and on the embryology parameters. There is no point in doing investigations after investigations because they are not pocket friendly and they are going to only incur cost for the patient. And patients may not come back for treatment. And in turn, we'll be doing more harm by doing more investigations. So we have to work on the stimulation and embryology rather than doing more and more investigations is what I feel and what I follow.
Okay, so we do have lots of inputs about DFI, and a few of our panelists had said about recurrent ejaculation, antioxidants. I think treating the cause and then going ahead. And What about, as we all said, maybe later we would want to go ahead with day 5. So mainly for this case, day 3 versus day 5 transfer. We had a discussion on that. What about this test?
Deal with cases of RIF. Yes, we absolutely give this counseling. This is not a case of RIF, but still that we go for day 5 for the very reason that we want to see embryonic arrest, and no embryos would mean no transfer. It is so much better to know that these embryos have got arrested rather than just stipulating and then blaming the uterus and thinking it's not implanting because of uterine factor, wherein we know that 70 to 80% of the times it's embryonic. So I would definitely counsel this patient, and no embryo would mean no transfer.
And what about this testes using testicular
We tried
sperm?
in few cases and we really did not find a superior results, and we have given up on for this particular indication of testicular sperms.
Sir, you have any experience with this testicular sperms for previous IVF failure?
Sometimes we definitely use testicular sperm, especially when the patient with high DFI. We have patients with the DFI of say around 70 or 80, and with repeated antioxidants is not at all coming down. So we definitely keep the option of testicular sperm along with the ejaculate, and we inject as 2 different entities. Suppose we get say 10 oocytes, we inject 10 with the ejaculate sperm and 10 with the 5 each with the testicular sperm as with the ejaculate sperm. And for a comparison, it's a satisfactory result with the testicular sperms. But we don't have enough data to publish or something like that. But we do definitely get a better outcome with the testicular sperm. And this also scientifically more correct because we are getting more sperms which are less prone for damage to the DNA.
Okay.
I absolutely agree with Dr. Raju Nair. Testicular EKC should not be done routinely, but if it is a case of recurrent implantation failure and if the DFI is high, probably this is what is the same practice which we do as well. We divide them into 50-50. 50% with ejaculate and 50% with testicular sperms is what we do. And we have got enough data which will be published soon.
Dr. Noshin, you want to add something about this testes?
We do the same protocol as Raju sir said. And again, we can't say it's better. Sometimes it comes testy better, sometimes other way around. So can't absolutely say this is the holy grail.
That is why we keep 50-50.
Yeah.
So this
and
is
one thing which add to the point that in cases like this, now we nowadays use a lot of calcium iron for treatment because it definitely increases fertilization rate. So that one thing which we can consider when the sperm selection methods are not of much use, this calcium iron for treatment of during fertilization can be of much value in improving the fertilization.
So that is if there is any previous fertilization failures, you mean to say?
Not
routinely.
Yeah. I mean, it's not for previous fertilization failure per se, especially if you're seeing a very bad quality of sperm sample, then we add calcium to enhance the chance of fertilization.
Basically, poor fertilization failure, fertilization failure and poor quality embryos and very poor sperm sample.
Okay, so I think we can move on to our next case. We have got enough inputs about sperms and previous IVF failure. So this would be our third case, 38-year-old with regular cycles, married for 8 years. She's got history of previous 3 IVF failures, which was done 5 years back, out of which she had 2 single blast transfer twice. And once it was a day 3 transfer, 8 cell grade A. And now presently her AMH is 0.9, AFC is 6, BMI 25, husband side semen analysis normal, and she has come to us for a final try. So what do we do now? And she is being scheduled for IVF. So what would be the option of stimulation protocol to start with this patient?
I would still go ahead with, an antagonist protocol, but the only thing is she's 38. At 38, theoretically, she needs 12 oocytes because keeping a euploidy rate of about 30%. So out of 12 oocytes, she will possibly make one euploid embryo. So this counseling has to be done. And in these particular cases who are still very keen, because 5 years back, the cause could be something else. Now it would be an oocyte for sure. Even could be both combined, uterine factor and oocyte, but first is going ahead and making some acceptable embryo. So I think if she's still keen on the last try, first of all, I will talk about dual stimulation for her, because I think embryo pooling is a very important factor. Though PGTA does not seem to have so much role in cumulative, pregnancy rate, but if I have to think of optimizing or efficiency of IVF, yes, I may offer, provided she forms, 2 blastocysts or more. If she forms only one, I would just, close my eyes and transfer.
Okay. Any other?
For this patient, I prefer probably a low protocol, even though the image is a bit low, and which start with the HMG of 300, basically of the best quality HMG. Because at the age of 38, with an agonist protocol, there can be a problem with low LH. So definitely the stimulation part will be a little more than what we usually go. And the aim should be to get more number of oocytes and more number of embryos. And as Shweta said, the main agenda will be to pool the embryos, so that since it's a last try with her own oocytes probably, we should use all the machineries in our armamentarium. So we should go for a day 5 embryo, day 5 culture, and do a PGT, identify the best embryo, and if possible, do an ERA and do the transfer at the right time. Because if finance is not an issue, I think we should give an all-out try and try to get the maximum forward.
Can I add on?
Yeah.
I would like to do karyotyping of the couple because she have done 3 failures. She has had 3 failures, and the stimulation, as rightly all said, that's the same thing. Basically, embryo pooling is the key. But then the karyotype, if there is abnormality, then only I would suggest PGTA, because PGT for me, the PGT1, PGT2, the current PGT, all the trials like the ESTEEM trial, Rubio trial, the STAR trial, none of them showed. Even the funded trials were not able to save PGT. So it consistently shows there is no difference. And even the post-hoc analysis also were not able to find any difference. So I wouldn't suggest PGT. The STAR trial is saying that for the older age group, you can do PGT, but then it's not practically possible for a woman of 0.6 or 0.8 AMH to get that many embryos to day 5, and that too the biopsyable embryo. Not all embryos will be biopsyable. So that also is a challenge. And another thing adding to that is that I've read an article by Velasco where he said that even the technique of biopsy plays a role in the pregnancy rate. So if not done in the experienced hand, that can also actually lead to embryo issue. So PGT is something which I would recommend only if there is a chromosomal factor.
Okay, so this
I have a different opinion on this. See, just because karyotyping is abnormal only, then we should suggest PGT is not the right way to approach, is what I feel. But here, as all of you have mentioned, embryo pooling and then getting the maximum number of embryos is the key. What kind of protocol depends. It is not that only this particular protocol has to be used, but ultimately we have to get more number of oocytes. But now it is not that, yes, PGT has got its own drawbacks, especially with it is invasive PGT where 10% of the embryos can be lost. But now currently we have got non-invasive PGT. It is not that it should not be done at all. It can be done. It can be offered. Only thing is it is not going to change the cumulative pregnancy rate, but however, it is going to decrease the time to pregnancy. So it is something which we can offer. It is not that it should be routinely done, but if the patient says, no, I have to try, and, if at all, if there is any investigation which, you want to see what it is, even though karyotyping is normal, does not mean that the embryos will not be abnormal, especially with the, she's more than 35, she's 38, nearing 40. She may have certain chromosomal issues with the embryos, which will become a prognostic tool for us to explain, see, this is what is happening, so that it is a tool for us to counsel the patient And if at all, if it comes normal, as I told, that the time to pregnancy will definitely decrease and the probability will be definitely better, which is approximately 80%. When we transfer a euploid embryo, the probability of pregnancy is 80%. In this case particularly, because already she is frustrated with repeated failures. So probably giving the chance with euploid embryos still holds good.
Can I add on?
Yes, please.
So I don't know who all does non-invasive PGT, but as if the non-invasive PGT is still in that evolving process, its result is not still as
I do.
yeah. So the
I do not.
Got it. So even the latest ESHRE public the meeting where they the proponents of PGT, non-invasive PGT, they were saying they had some 80 to 85% concordance with the PGT biopsied embryo. So it is still not in the, it is still, they're trying to level that gap yet. That is one thing. Second issue is that we really don't know. You might have heard about the mosaicism. There is a 20% mosaicism existing in all the embryos. So when we do the biopsy and we do get an abnormal finding and we don't transfer these embryos, there's a study by in NAGM where they have segregated these embryos and finally transferred, and out of them a considerable number of babies were born as healthy. So then comes the question of, if we are not transferring these embryos, potential embryos which has a good live birth chance, we're actually denying them. So the current recommendation, even in the RPL and RIF, obviously everything is a gray zone in RIF, but RPL ESHRE guideline is that PGTA is not recommended if the karyotype is not abnormal. Karyotype result is normal. I'm not talking about RIF, RPL. So I'm trying to extrapolate with all this logical reasoning being, you know, the mosaicism, where the trophectoderm biopsy may not be the true representation of the actual embryo, how many embryos to reach that site. So all these factors actually make it very difficult for us to judge and choose something where, you know, we really don't know.
See, this is what, see, when it comes to non-invasive PGT, it is representative of the inner cell mass. That is the advantage of non-invasive PGT. All this while, when we were doing PGT with trophectoderm biopsy, yes, there were chances of, or we were skeptical about mosaicism, true. And also it was not representative of the inner cell mass. But the non-invasive PGT, even though a lot of studies more to come, but this is the advantage. And also we don't have this fear of losing the embryos because of the biopsy procedure per se. And as I told, it is not a routine, but it can be offered. And many a times we have seen that there are aneuploidies, and also there are multiple abnormalities with the embryos, not just mosaicism, but there are other abnormalities also with the embryos, and definitely the time to pregnancy will be lesser. Especially when it is advanced age, it is rather a good tool to add on to our armamentarium, but not as a routine though. If it is recurrent pregnancy loss and even recurrent implantation failure, it can be suggested. And one more thing is, evidences cannot be treated as IPC section so and so, and the guidelines cannot be treated as IPC section so and so. We have to have our clinical judgment as well. See, why do evidences come? Why do guidelines come? It is because we have to have a standard protocol. When we have to publish studies, we are on the same platform to say, okay, this is what is the touchstone. This is the corner. This is the touchstone. This is on this we are building our case. But when it comes to the clinical judgment, it is not that we always have to follow guidelines, but probably at times we also have to make individual clinical decisions. This is what is my opinion.
I would like to rest the case by saying that it's the logical reason which made me say the decision, but I leave it to the audience choice.
I think the biggest question in this particular case is two.
Yeah.
One is previous 2 failed embryo transfers when she was younger in age. The second is she's sitting with us now at 38 and wanting her self-oocyte. So this is what we need to concentrate. So the first and foremost, I think our aim will be that whether can we even get enough embryos. The first step would be that, because there's a very high probability that the cycle may just get cancelled. She may have just 1 oocyte, she may just have 2, no embryo conversion. There will be so many adversities what we will be preparing this patient for. So PGTA is such a far-fetched discussion. Here the discussion will be there, but yes, we also have to think that why implantation did not happen in the previous cycles.
Yes.
Perfect.
Oh, what about this adding growth hormone during stimulation in RAF patients especially?
I don't do it.
Okay.
Previously,
growth
maybe
hormone
around
is
7-8 years
One wants
back,
to
I
add.
used to do,
Yeah.
but nowadays I hardly do growth hormone.
Okay.
growth hormone is specifically not for recurrent implantation failure. It is only for poor responders. There are a lot of evidences previously which showed, yes, it is, good. But subsequently, like, 2019, 20, again, meta-analysis have come supporting growth hormone. But again, it is not in terms of improving the number of oocytes. It is in terms of those patients who had poor embryonic development. So that is one thing which we have to keep in mind. And also one gray zone is, what is the dosage of growth hormone? When do we have to start? When do we have to stop? What is the dosage? These things are not yet clear. But so for this, probably, if at all we are using growth hormone, we have to use it in research settings. And probably, since the evidence is out saying that it may help in poor embryonic development, we have to clinically judge and see whether this particular patient may benefit. If there is previous poor embryonic development, we may choose, but not routinely, and definitely not in recurrent implantation.
Yeah. Okay. So what do you opt for, fresh or frozen transfer? Or when do you opt for fresh transfer? When like if you are getting less number of oocytes, do you opt for fresh transfer or always go for frozen? What is your say on fresh and frozen?
I don't believe in the freeze-all strategy, because we have to individual. Nothing is like blanket therapy for all. So we have to individualize. If the number of oocytes are good, she's a normal responder, or she's a poor responder, she just wants to go ahead with only one cycle. And if her hormone parameters are under control, especially the progesterones, and her endometrium is very good with good morphology of the endometrium, why not fresh? I can do fresh. But if the progesterone is more than 0.9, or if I suspect there is endometrial follicular asynchrony and she's hyper responder, in those cases, or if the endometrial pattern is not good, then I would go for a freeze-all strategy.
Okay.
Basically, individualized strategy is the best thing.
Yes.
2-3 things which I decide on fresh transfer versus frozen transfer, especially in a poor responder. Basically, on the amount of gonadotropins which you use. If I use more than, say, 3,000 units of gonadotropins, definitely majority of the time I feel the endometrium is going to be bad. And in that case, I definitely cancel the cycle for frozen ET. And second, on the day of trigger, serum progesterone level, if it is high, it's almost a universal truth that we should postpone. So this, and majority of time when we stimulate more, there is a very high probability that the endometrial asynchrony will be very, very common. So these are the 3 major indications that we avoid fresh transfer for sure, and obviously go for a frozen transfer. But at the same pretext, I'd like to highlight one thing. If the embryo quality is not that great, that means if that embryo is not able to sustain the freeze-thaw cycle, then definitely putting back the embryo may be a wiser choice rather than wasting that embryo.
Okay. So what about Ira for this patient after freezing her embryos?
Would not recommend.
I personally don't believe in receptivity array, because we are not looking at a point of implantation. We are looking at a window of implantation. As we know, window of implantation is anywhere between 3 to 5 days. But here, we have done our own study, and we have even published it, where ERA is not going to help. Even after doing a personalized embryo transfer, statistically, we did not find any difference in improvising the results. And as the scientific hypothesis says, that we are not looking at a point of implantation. We are looking at a window of implantation. It can't be as narrow as it has been promoted and suggested through specific groups.
Okay. So
we have tried ERA for a long time, and then we were not able to provide that consistent results. It was quite more of a luck by chance. And even when you look at the studies published by ERA, it's all by the same group. Even the latest publication of the 5-year trial, also it's by the same group, which make us question whether the credibility of it. And another thing, that with quite a landmark study where they actually done by EV group, where they transferred 3 euploid embryos in each FET cycle, and then the cumulative pregnancy rate was around 95%, which means that, the contrary to the belief of 25% uterine factor or the endometrial receptivity factor, it is just narrowed down to 5%. So the absolute requirement is that means that the embryo is a key driver for the implantation rather than the endometrium. Obviously, there might be a small subset of population which requires it, but it cannot be extrapolated for all.
Okay.
And in the study, what we had done on ERA, surprisingly, we found a important finding, which means the displaced window of implantation was more so or more common with women who had advanced maternal age and who had who have poor ovarian results. So probably, so both the ovaries and endometrium are in sync, and that is how probably they may have little bit displaced window of implantation. Other than that, per se, correcting the window of implantation, whether it is going to give us better rates, the results were not statistically significant.
Okay, let's move on to immunotherapies in RIF. I think these days we are getting a lot of studies coming up, but still evidence is questionable. Can panelists pour on their thoughts about immunotherapies in clinical practice for RIF?
I only have one statement that we don't use either of the four at all.
Me too.
Okay, Dr. Divya.
My institution, and we practice ERA. So I did not comment. Anyway, we have gone beyond that discussion. But these intrauterine therapies, absolutely no.
Okay, Dr. Divya, what about your say on intralipids?
Absolutely no, because again, we have published a study on natural killer cells and also IV immunoglobulins, where it is not of much help. Where do we give, first of all, the scientific hypothesis came from, where do we give IV immunoglobulins? Probably when the natural killer cells were high. But as we did the research and as we studied further, it is not just about the number of natural killer cells, it is about the kind of natural killer cells. What is the type of natural killer cells which are available? And also, as I said previously, implantation is akin to inflammation. We have to have some kind of inflammation. So we cannot bunk it down by giving any immunotherapies, like whether it is steroids or IV immunoglobulins, whatever, because in fact, we'll be doing more harm than doing good. So where exactly it is going to work is what we really don't know. So empirically using them is not good. For example, you may think, okay, what is the harm in, even though it is not doing good? Can we use it empirically? Again, the answer is no, because the cost. As I told earlier, repetition is the key to success. If we give immunoglobulins in this particular cycle, what is the extra cost which is going to be incurred on the patient? So the patient will not be financially and emotionally stable to come back to next therapy. Because they are already financially exhausted, and also psychologically, because so many injections, especially in the luteal phase support, I have seen prescriptions where the prescriptions runs up to 17 to 20 medications. The patient will not be eating food, she'll be only eating tablets and taking injections. So many medications will be there in the luteal phase support, which is definitely not advisable. So I say absolute no to immunotherapy.
You want to add anything about immunotherapies?
No, I think it actually is beneficial only for a very small subset of population, but we don't know which group it is. That immunological infertility belongs to a very small subset, and all this, as Dr. Divya said, the natural killer cells are different type, peripheral, uterine, and this uterine itself is very different in every cycle and where you biopsy. So it doesn't correlate, and many times, something works for one patient, we try to extrapolate to all patients, trying to, save them, but it just doesn't work.
There are lots and lots of studies coming up, but still, and they do biopsy and they find out what type of
intralipids and IVIG can have a lot of side effects besides the cost, and we should not be doing it. And we all are not in the research settings. The problem comes is when consultants come under pressure, when patients come with these histories of repeated failure. But most of the times, they are embryonic. Again, good labs making good embryos is something which is so important. And that is the crux of matter. By changing to a better lab, maybe better embryo, better culture conditions, and better pregnancy rate. So that is must, I think, of utmost importance, rather than, so this pressure. So what we practice, we don't practice, we just don't prescribe to them.
Yeah, add-ons in IVF is always questionable. And I think better we need to stick on to the good quality embryo and lab. So we'll move on.
Recurrent implantation failure is just a presentation. It's not a diagnosis in itself. So why is it failing? And also, is it a recurrent implantation failure or IVF failure is what we have to understand. Implantation failure is one we don't find any cause. Majority of the times, I think only 10% of the times are actually recurrent implantation failures. Other 90% of the cases are recurrent IVF failures where we will be able to find out what is the cause, either correctable or non-correctable. But however, when we counsel patients, this is what we have to look at, whether it is IVF failure or implantation failure.
Okay, thank you. I think we'll move on to our next case. We'll finish it off. This is 33-year-old, married for 4 years, irregular cycles, known case of PCO, with hemorrhagic cycles, BMI 32. She had her endometrial thickness about 18 millimeter with a polyp sitting at her os. And so she was scheduled for hysteroscopy with polypectomy and endometrial sampling, which turned out to be complex hyperplasia with atypia. So later, there was a tumor board discussion, which decided to schedule the patient for controlled ovarian stimulation, embryo cryopreservation, then go in for a progesterone therapy, and later frozen embryo transfer. So after obtaining detailed consent from the patient, then she was scheduled for IVF, where antagonistic protocol was done, and 12 embryos were cryopreserved. Then later, she had therapy, progesterone therapy with megestrol, that was for 6 months. And then her endometrium was thin, biopsy done, there was no hyperplasia, and now she is for embryo transfer. So I would like all your thoughts over these type of patients with thin, especially after this progesterone therapy. How do they go? So number one, when you take her for a frozen embryo transfer, what type of protocol do you opt? And this patient with irregular cycles.
So it's very normal to find a thin endometrium after giving progesterone for so many months. You actually need a washout time of 1 to 2 months. And obviously, we have to be careful, try to do to the natural cycle if possible, if the endometrium is developing, or with a very low dose HRT. I would prefer to wait for the 2 months so that, her cycles resume. And if it was irregular cycle, then obviously you might have to add low dose estrogen. But again, if given a choice between estrogen, I would prefer a transdermal one over the oral ones, because that's supposed to be more physiologic.
Yeah, modified natural cycle may be a better choice for this patient.
If it is regular cycle, yes, sir. But it's mentioned that it's irregular cycle.
Yeah, it's very difficult.
We can give a letrozole stimulation and
we can try that. Yeah. That too also works.
Yeah, this patient, and after a washout of 2 to 3 months, she was given letros, and there was follicle which was coming up, and endometrium was thin. So we had to cancel the cycle. So this patient, I mean, how are we justified in giving estrogen supplementation from the beginning, if at all we are scheduling her next? So that is a thing. And we are already, and what would be the time period where we can wait for her endometrium?
So, yeah, we come across these kind of cases on lesser occasions. Every time megestrol was given, the endometrium just conks off for a couple of months. I think I would give a low dose estrogen. And even if the endometrium is 6.5 or 7, she has good embryos, I'll transfer it, because I don't have much, scope in this case. So I can't wait for 9 or something like that, because then she will start jumping her endometrium.
So this is the pregnancy results with those type of transfer. What was how was it?
I can tell you one very recent case, my patient, same kind of case. Ultimately, what happened, that was in January. The first one was negative. The second one, she landed up in missed abortion and she went for surrogacy. So that time, that option was available. But now we don't even have that option.
Okay.
Most of these atypical hyperplasias earlier, if I can very clearly remember, I think more than 50% landed up in surrogacy, because these were the constant issues. The endometrium.
Resistant, I feel they are very, very resistant for implantation.
Resistant, missed abortion, failure to make endometriums. And then one girl again had CNC2 because her husband landed up in an accident and she just didn't come for 1 year. And after that, she had CNC2 and we had to do her hysterectomy. Embryos kept, So many challenges. But I think low dose estrogen, moment she forms 7, just transfer it.
Okay. And how often, for this patient waiting for 3 to 4 months had a transfer, and after failure, do you repeat an embryo, endometrial biopsy now after failure?
If it gets thick, yes. If it is still thin, because she's recently had a biopsy, I will go for another transfer. But if I still start seeing irregular endometrium, a little cystic, little thick, then I will repeat a OPD-based biopsy through PIPEL. That's the easiest. And then I can put her again on progesterone. So I think this waxing, waning, and fine-tuning will be required.
But I think, these people, they don't get very thick endometrium also. But 8 to 10 also, I think we need to do a biopsy, because when we give this low dose estrogen in 1 or 2 cycles, then we land up with problem again. And how many cycles
and
can
biopsy, if at all you're doing, as per, you would agree with me, Dr. Geeta, as per the RCOG guideline, they suggest to do hysteroscopic biopsy, because what we are doing might be the area where, where actually the hyperplasia may not be the true representation. So if we are doing it, we should do actually under hysteroscopic guidance.
Yes, that is what evidence says. For these type of patients, it should be hysteroscopic guided. And how many cycles after stopping Megestrol or Mirena for these type of patients do you usually see getting an endometrium? Approximately 4 to 5 months, 6 months?
After 3 cycles.
No, earlier than that.
Well,
3 cycles.
after 2 months. After 2 months, we start saying that.
Okay, fine. Okay.
Earlier, before again the hyperplasia sets in, it's better to see them earlier and do the transfer.
True.
This patient, actually, she had a failed transfer, and then one more embryo transfer she had, and with low dose of estrogen, because she did not get her endometrium, and which failed again. So it is really, really tough for these patients. Very, very tough. Okay, it was really a nice discussion with previous IVF failures. Thank you, panelists. I think we can wind up our session today.
Thank you
so much.
Moderating very well.
Yeah.
Thank you, Dr. Geeta.
Thank you so much.
Thank you,
We are running late, and it's almost 1 hour. I didn't want to speed up the session because it was in full flow, and I want all our audience to benefit from this. So I think we can go on. It was really wonderful having all of you from all north, south, Bangalore, everywhere. Thank you so much.
Thank you.
Thank you.
Thank you very much, Dr. Geeta, for calling us. It was a lovely panel.
Thank you, ma'am. Thank you, sir. Thank you, Dr. Divya, Dr. Naushin. Dr. Reshmi, I think we can start. Dr. Reshmi is our consultant from IRM, and she has done her IVF training and ultrasound training, and she is here with us for the past 4 to 5 years. And Dr. Reshmi, you can go ahead with your vote of thanks for the session.
Thanks, Geeta, for the introduction. Hello, everyone. It's my privilege to deliver the vote of thanks on this occasion. We would like to thank M Hospital and Dr. Kundavi ma'am for giving us this opportunity to conduct the scientific program. I'm sure everyone have had great learning and several take-home messages now. I thank Dr. Vani Pujari for her excellent talk on the topic of thin endometrium and its challenges. Hopefully, we are able to face these challenges and get over them now. I would like to thank Dr. Sujata, Dr. Parasuram, and Dr. Priya Kannan for the brainstorming debate. It was a very informative argument which went on. I would like to thank Dr. Madhupriya for briefing us on ERA. I finally would like to thank Dr. Geeta and all the panelists for simplifying how to handle the previous IVF failures. That was a real challenge that we have to face and deal with the couples with IVF failures. It was very elaborate and very informative panel discussion which went on. Thank you all. I would finally like to thank Mr. Mahesh and Mr. Ganapati, our EDP team, for the technical support behind the program. Thank you all for this evening. It's been great pleasure to have you all. Thank you all.
Thank you, Reshmi.
Thank you, Dr. Geeta, for the wonderful panel. I enjoyed thoroughly. I think you've drilled all the the panelists, and the panelists were too good. I mean, I really
All
enjoyed.
because of the panelist.
Yeah.
Thank you,
Everybody
ma'am.
were coming out with the great discussions and the great points. Thank you so much.
Thank you. Thank you, ma'am. So we'll hope to meet everyone again another session. So
Yeah, that will be in probably August. We have maybe coming out with the fetal medicine. Thank you.
Thank you, ma'am. Thank you.